So, good morning, everyone. It's a great pleasure to be here with you and uh, having this workshop that will run today from now on until 13 hours local time. We're very happy that we had a very responsive contributions from the general community. We in fact managed to make this program out of about 40 presentations. We almost one-third of them were oral, and the rest were posters. As we have told you, the oral presentations will be here. All presentations will have the ability to be presented in this room, either in a longer presentation, about 7 to 8 minutes, the oral ones, with 2 minutes or 3 minutes for discussion. And the poster ones will have a shorter presentation. That means up to 3 minutes with discussions. And the poster presentations, but also some of the oral, have the ability to go to the sometime until say after 10 a.m. until the end of the workshop, until 13 hours to upload their poster in the other building. Probably you have seen in the ARC building 4E. It is the area. All posters have been will be set up there. So it's up to you how you will manage. If you are alone, you can go put there the poster. You can have the presentation here and share your time. If there are two persons from your university, you could split or whatever. So what we tried is to have all presentations at least being presented in this room. So we have this ability to have discussions. We have two invited talks. The one will be at about 9 o'clock after the first session, and the other will be, I think, about 11:45. We'll see it. We'll give you all the presenters in due time. We want to thank all organizations that provide us with support, financial organization, and these are listed in our proceedings in the website that we have. Specifically, we would like to thank Dairy
from QMUL.
Dairy Institute for QMUL. We will have to Amazon Web Services, GRNet from Greece, and ICCS, and QMUL, of course. And so it is a pleasure that as we will describe during the workshop, we had two, and I will present in a minute. The title of the workshop and the work we have focused, and as you will see in the presentations, most of the the papers on the workshop deal with this issue. We try to see how domain adaptation is a good tool for medical imaging, and how this can be implemented in the framework of the current state of the art. Similarly, explainability, interpretability, and fairness are issues, are characteristics that we need to have in our developed approaches. So some of the papers focus in this issue. And then we have various applications that the papers we have accepted deal with. The organizers is Dimitris Metaxas from Rutgers University. Dimitris had this morning, he had an invitation from his rector that they need to speak about AI implementation in the university. So he will be here near the end of the workshop. I hope he manages. Otherwise, you can, of course, contact him for everything you may need. Myself, I'm Stefanos Kolias. I'm professor at National Technical University of Athens. I'm also leading, chairman of the National Infrastructure for Recent Technology in Greece. And I'm also partially professor in University of Lincoln in UK. And so we are the main organizers, but the real people that have done also the work has been Dimitris Kolias from QMUL, Xu Yongye from Lincoln, and Francesco Rudo from ST Microelectronics in Italy. So we wish to thank all of them. we wish to thank you all for participating, for contributing with papers that were of high quality, and it will be interesting to see how we will have a fruitful discussion today. Okay.
But also, someone has asked to swap the displays. Let me find this.
We try to finalize any setup that we need. So in general, the whole workshop had two main streams. The first has been the mainstream of the workshop, where we ask the community to provide papers dealing with all these technologies and applications. You see here that we got a lot of papers related to explainable AI, to foundation models, to large unimodal and multimodal, especially visual and text models, both dealing with unsupervised, self-supervised, and machine learning and deep learning methods for medical diagnosis. Our aim has been to see how we can really deal with effective and adaptive diagnosis, domain adaptation, generalization, segmentation issues, classification, trustworthiness, justification of decision-making process. So all the papers that we will hear today deal with these issues. And we also had a competition dealing with two challenges. What we have done has been to use, as you see in the bottom, and some extra from a big database we have developed using data from different hospitals, and of course with a permission and anonymized. And so we have created a large database that contained 3D chest CT scans. We provided extract of this database to these challenges. So the first has been for building effective interpretable models for fast and reliable COVID-19 diagnosis based on these data sets. And the second challenge has been to use domain adaptation methodology, so to diagnose COVID-19 across different environments, medical environments. That means some of them we knew because they were annotated data sets, but the other were non-annotated. So we'd like to see how domain adaptation could perform in this frameworks. So these two challenges we had, as you will listen later, winning teams who got awarded and so on. So we have, I think, a very rich program of presentations today. I will stop here because we'll go to the real presentations. And the first session consists of, I think there are 5. I don't know if one of them is here. I think we're missing one, but 3 of them are live, and one will be in because the presenter did not manage to get their visa soon. So the last one, I think, will be through the web. So I think I'll stop here, and I will ask the first presenter, which to make the presentation on cluster triplet loss for unsupervised domain adaptation on histology images. It's Ruby Woods, I think, from Oxford University, UK. Thank you very much, Ruby, for being here. And do we have it here? Yeah, the floor is up to you. Until we find it, and I give you the floor, I may add that in the first session, we have 3 presentations dealing with domain adaptation technologies applied to different medical imaging applications, one dealing with interpretability, and one dealing with how large-scale models like a segment anything model plus clip can work for zero-shot segmentation in applications. So I think this form the first presentations in the context of the workshop.
And stage is yours.
Okay, hi everyone. Okay, great. So here we are presenting our paper on, thank you, cluster triplet loss for unsupervised domain adaptation on histology images. So this is building off this previous model that we developed, which we presented at MICAI last year. This model, you can see the paper if you want to learn more about this, but it was trained and validated on 2 separate cohorts of patients. And then when we validated it on the validation part of those data sets, we achieved 0.93 AUC for this prediction of patient response to radiotherapy treatment, so a binary classification problem. However, when we implemented this model on a 3rd unseen data set from a different geographic region, it performed very poorly and only achieved 0.54 AUC. So maybe if we look at the data a bit more, we can see what's going on. So as I briefly mentioned, we're trying to predict how colorectal cancer patients will respond to radiotherapy treatment from their pre-treatment biopsy slides of their of the biopsy tissue, called histology slides. And so this is retrospective data sets of rectal cancer patients. And you can see in the table here, we have complete response, which is our positive response, versus no complete response, which is our negative response. So that's the binary classification. And we originally trained and validated on Aristotle and Grampian data sets. And then the 3rd unseen data set we're trying to adapt to is Salzburg. And so the complete responders, the positive response, are the minority class here, which is something important to deal with. And you can see in the UMAP projection of the unsupervised cohort features in the bottom right, the Aristotle and Grampian are kind of closer there on the right-hand side, but the Salzburg, the new data set, the target data set, is quite far away in the feature space. So already we can see the differences here and maybe why our model doesn't immediately adapt well to this data set. And so we wanted to develop a unsupervised domain adaptation technique to help our model perform better on this target data set. And so we looked at some methods currently in the field, but we saw that a lot of these existing methods use the current model on the target data as to kind of guide the predictions. So those predictions on the target data as pseudo labels. However, they rely heavily on the initial accuracy of the model. And you saw that our model applied on this data did not do very well at all. So that would just introduce noise and bias when we're using those predictions to guide our domain adaptation method. So we are proposing a new loss function to adapt our existing model to the new target data set. This method uses a lightweight clustering representation of the original source data, so Grampian and Aristotle, in the loss function. And we take the centers of those clusters of the source data and use those to guide the learning of the updated model. And so we are trying to move the feature space of the target data towards the closest cluster from the source data, but also repel it from the furthest source data cluster. So trying to shift that domain of the target data or the features from the target data onto the domain of the source data. And then ideally our model would be able to better predict from those features. And so the clustering approach we used was k-means. It is often found to be one of the best, most robust methods. And here we've just visualized the 5 clusters, which we found to be the optimal number of clusters. And you can see some morphological kind of patterns in those clusters. And so here's our loss function in a bit more detail. So we calculate the distance between the target samples, so the target features, and the source cluster centers, those 5 cluster centers. And then we find the closest and furthest cluster centers by the, min and max of the Euclidean distance. And then we use those closest and furthest source cluster centers as the positive and negative examples in the triplet loss function, and then take the mean and backpropagate. And the intuition here is that when the target features are really far away in space, in the feature space from those source features, the loss will be very large. However, when those target features move within a reasonable region of those 5 clusters, depending on the size of that domain, then the loss will be very small. So we're not trying to kind of shift the domain exactly, but it's just bringing it into that region. And so here are our results. So the top line is our source method or source model on the target data before any domain adaptation. So that 0.54 AUC that I mentioned before. And then we've also implemented 4 state-of-the-art unsupervised domain adaptation methods. So distilled soda is the only one here which was also implemented on specifically for histology images, this type of image I'm looking at. And then the other 3 come from the more general computer vision field. And you can see the results here. And then the final line is our proposed method, which, as you can see, outperforms the other methods. And so not only do we have the metrics, but we can visualize this domain, this feature space domain that I keep talking about. So on the left-hand side is the UMAP projection of those features from the source model before domain adaptation. And on the right is the UMAP projection of the features with the adapted model. And we have colored these features by whether they're target or source data, and whether their labels. So complete response, which is our positive response, or no complete response, which is our negative response. And so before domain adaptation on the left-hand side, you can see that the purple and red, so the source data, positive and negative response, are fairly well separated. And that kind of reinforces the competency of the source model, which we saw on that data. But the target data is not kind of well separated and not kind of overlapping or in the domain of the source data for the corresponding labels. However, on the right, after our domain adaptation technique, you can see that specifically for that minority class, that positive complete response class, so that's in green, the target data has moved onto the domain of that source complete response, so that source positive data. So that means we can much better predict, in particular, that minority class of the complete responders. And so we did some ablation studies, more can be found in the paper, but one of those studies that we did was on the number of clusters, in case you are curious. So we found 5 optimal clusters, but if we used 3, 4, 6, or 7 clusters, the results were still, an improvement over baseline, but nowhere near as good as that optimal clustering. So that kind of highlights how key that part is. And so to finish off, future work in this space could be to do with updating the classification branch, because I only focused on the feature part of the model for this domain adaptation method. And then we would also want to think about how we could extend this to further cohorts. So would we update that cluster representation each time? It may be an accumulative approach. How could we develop this? So thank you to everyone involved. And does anyone have any questions?
Thank you very much. Is there some question? The only thing is, I don't think they have some microphones.
Yes, if you want, maybe you can ask the question, we can repeat it so that also the virtual attendees can hear it.
Yeah. Yes, why not?
Could you correlate the distance in the UMAP space with the performance? Like you showed the projection, there were some points that were very far from the source data.
Here?
Yes.
Mm-hmm.
And were those points less well classified, those samples?
So we didn't look into that, but that's a very interesting idea. So these points exactly are the node features. So the underlying model we're using here is a graph neural network. And so those are the node features from that graph. And so to get the graph level prediction, we aggregate the node features. But this is just, you can kind of represent that data better with the node features here. But yeah, that would be very interesting to see. I don't know. Thank you.
Thank you. Any other question? This year.
Actually, I have a question. So, Ruby, thank you very much. I know you mentioned that you use K-means because that's proven one of the best ones that exist. But the question is, have you tried also to use either agglomerative clustering or in AAAI this year, there was an interesting paper in my approach, it was fair K-means. I don't remember the exact title, but it was something like this. So did you try any other method apart from the pure K-means algorithm?
Yeah, so I did try different methods. The K-means one turned out to be the best, but I also tried some hierarchical methods with self-organized maps, kind of, you know, some fancier methods which were fun but didn't turn out to be as effective as K-means.
Okay, thank you very much.
Thank you.
Thank you very much, Ruby.
Thank you.
Thank you. So, thank you for this first presentation. We continue with the general area. The second presentation is on achieving reliable and fair skin lesion diagnosis via supervised domain adaptation. Yeah, I think it will be presented by Janet Wan from Tulane University. So, Janet, you may come there. Yes, as Ruby. Okay, you don't need. Yes, yes, yes.
Hi, everyone. I'm Janet from Tulane University. Today, I will present our work on achieving reliable and fair skin lesion diagnosis via unsupervised domain adaptation. This is a joint work with Yunbei Zhang, Zhenming Ding, and Jihun Han from Tulane University. First of all, let me start with our motivation for this work. As you know, a common challenge for medical imaging analysis is that the development of a reliable and fair diagnostic system for private medical data is often constrained by the scarcity of labeled training examples. So one potential solution is to leverage public data sets whose extensive condition coverage and rich condition semantics may practically benefit the training of a diagnostic model for our private medical data. When we consider these data sets jointly, these multiple public data set may help us fill the missing classes and reduce label prior shift. So this is another benefit of using leveraging multiple public data sets. However, naively aggregating the rich information from these data sets may aggravate the domain shift, as we all know. Here are some examples. I'm not sure if you can see it clearly. Here are some examples from well-known skin lesion data sets. As you can see, even the same type of skin lesions may look very different due to varying acquisition protocols, demographic distributions, or environments, etc. So the question is how to take care of these shifts, since we have to take care of these shifts when using these data sets all together. And in our study, we hypothesized that unsupervised domain adaptation with multiple sources may allow us to tap into the informative public data sets while taking care of these domain shifts. Additionally, we also hypothesized that the increased and well-aligned demographic information after UDA with multiple sources may help us mitigate bias against minority groups, thus improving the model's fairness. So our goal in our study is to investigate the effectiveness of UDA for training skin lesion classifiers with various public data sets when labeled data from the target domain is not available. That concludes our motivation. So what is UDA? UDA is a group of domain adaptation methods that aim to mitigate the domain shifts between source and unlabeled target domains. It can be categorized into two groups, single source UDA and multi-source UDA, depending on the number of sources considered. For single source UDA, existing works have proven that adversarial-based UDA is effective for melanoma nevus classification. And among them, DAN and ADDA are two of the most representative approaches. On the other hand, a multi-source UDA, there are moment matching and adversarial-based UDA for multi-source UDA, which are represented by M-cube SDA and MDAN. So in our study, we will leverage these representative UDA methods in their own category and investigate the training strategies, namely single source UDA, combined source UDA, multi-source UDA. And here's an overview of the training strategies we investigate. And let me break down these the illustration a little bit. So specifically for single source and combined source UDA, a single label source data set is aligned with the unlabeled target data set via a domain alignment component, which is marked in gray here in the figure, before it is used to train a classifier to predict the target data. In particular, a combined source UDA involves an additional step of aggregating the multiple data sets into a single one, after which it follows the same training procedure as a single source UDA. On the other hand, a multi-source UDA aligns multiple sources with the target domain simultaneously. So to validate our hypothesis, we considered 8 skin conditions across 6 data sets for both binary and multi-label classification. We used AUROC for binary classification and accuracy for 8-class classifications. And we used 3 matrix to evaluate fairness, taking different perspectives of being fair into account. And next are some results in our study. We first conducted melanoma versus nevus classification in our experiment. I think the font is too small. So here are results for the binary classification task, with each column representing the result for a target domain. So what we did here is that we artificially made each of the 6 data sets a target, and the other 5, the source data sets. An immediate observation from this table is that leveraging multiple data sets yields the best results across all target domains, as highlighted here in yellow. The best results are either derived from combined source or multi-source UDA training strategies, even when data from the target domain isn't available at all, validating the effectiveness of using UDA with multiple public data sets. Next are results for the 8 condition classification. And a similar pattern of results was also observed in this more challenging task, where combined source and multi-source UDA training schemes generally outperforms its single source and non-DA counterparts, as highlighted here. So we also conducted some further analysis, which shows that applying UDA with multiple sources forces a domain adaptation to integrate and mix well, as shown by comparing the first t-SNE plot with the third one, while preserving the separability of classes, as shown by comparing the second and the last t-SNE plots. Lastly, we conducted some evaluations on fairness using 3 data sets and the matrix we just introduced. We found that applying UDA on multiple sources consistently achieves the superior classification results while maintaining a minimal performance gap between groups. In conclusion, we conducted systematic investigation of single, combined, and multi-source UDA training strategies on skin lesion data for both binary and multi-class classification. Our experiments have validated the effectiveness of using multi-sources over a single source and established the superiority of UDA over non-UDA training in binary and multi-class tasks. And it's also helpful for improving fairness. You guys are welcome to stop by our poster or read our paper for more details. Thank you for your time.
Any questions from the audience?
Just for the virtual attendees, if you have any questions, you can always post it in the chat and we can answer for you.
Okay. No question for this? Okay. Okay.
Thank
you
you
very much. Okay.
Actually,
Yeah.
can I ask one question?
Okay, sure.
Thanks for the presentation. So the idea is, in terms of future work, how do you, because you had like a specific section on fairness.
Yeah.
What are your future plans? Do you want to delve into more details about fairness and maybe explainability of those algorithms? Or
Yeah, that's one of the future directions we are considering delve into. So we haven't figured out what is the factor contributing to the improved fairness. But we hypothesize that it's because of the increased and well-adapted demographic information from the minority diverse groups in the public data sets.
then for fairness, there exist also different measures because there doesn't exist a uniform measure that, you know, if this works, then you know that it's totally fair. So it also may be interesting to check, you know, different performance metrics.
Yes, that's true.
Okay, thank you very much.
Thank you.
Thank you. So, thank you very much. We're moving to the third talk, which is entitled Source-Free Domain Adaptation of Weakly Supervised Object Localization Models for Histology. It will be presented by Alexis Guisselet from École Technologie Supérieure in Montréal.
Just a moment. Over to you.
So hi everyone, I'm Alexis Guichemet, graduate student at the ETS Montreal, and I'm here today to talk about source-free domain adaptation of weakly supervised object localization for histology images. Well. Okay, so if you look through this, you lose the investment. Yeah, just the USB gets disconnected sometimes.
Okay.
So histology images are playing a crucial role today in cancer diagnosis, but there is important intra and inter variability for the grading, so it can be challenging. And now with the emergence of deep learning, that the problem is those models for classification, they are considering as black box. So it can be very important to develop new models that allow to have like a visual interpretability. So we need to add the localization in addition of the classification. But the problem is that with all slide images, they are captured at a very high resolution, more than millions of pixels. So doing the pixel level annotation can be very time consuming and costly. So there is new techniques called weaklist provides object localization that allow to have a localization, which is like linked to a classifier prediction. But the problem is the performance of those methods tends to decline due to the domain shift between different target domains. And so we can think about doing like domain adaptation for those models. But in our field, we can assume that given the privacy and the confidentiality challenges, that maybe the source is not available. So we can focus on source-free domain adaptation. So this paper is more about like a survey, and we try to understand how do source-free domain adaptation techniques perform in a weaklist provides object localization context for histology images. So briefly, weaklist provides object localization or techniques based on CAMs, which is class activation map. So it's just techniques that are based on the response of the convolutional layer to a class prediction. And in class activation map, after interpolation, that the strong spatial activation tend to represent the most discriminative region of interest. So there is a lot of techniques today that allow to do a weaklist provide object localization. Here's like a quick taxonomy for those techniques. So there is two main families, which are bottom-up and top-down. So for bottom-up, we have just the forward pass information within the model, while for top-down, we exploit the backward and forward pass information. So in our paper, we consider different techniques to perform the localization, which are DeepMill, TSCAM, and GradCam. So now for source-free domain adaptation, there is a lot of paper who have been published recently, and there is some surveys too. So here's one of the taxonomy that exists for doing source-free domain adaptation. So there is two main families, which are white box models and black box. So for white box, it means that we have access to all the information within the model, while for black box, we just have access to the output of the model. And in our paper, we mainly focus on white box models. And we just use like 4 subcategories, which are domain distribution generation, domain alignment via statistics, island structure mining, and contrastive learning. So one of the paper that we consider is this one. So they try to estimate the distribution of the source. So for that, they assume we can just consider like the distribution of the source features or following a Gaussian distribution. So they are using the weights of the classifier and the target features to estimate those Gaussians. And once those Gaussians are estimated, then they're just doing the alignment between the estimated source features and target features with MMD. The other technique that we consider is SHOT. So it's a technique that tries to maximize the information during the source freedom adaptation process. So there is two loss function, one which is information maximization. So there is an entropy loss to make sure your model is more confident in its prediction. And at the same time, there is a KL divergence to make sure your model doesn't focus only on one class and consider the other classes. And also it's supervised with some pseudo labels obtained from k-means. The other technique that we consider for the paper is based on contrastive learning. So here they're just trying to push features with the same pseudo labels, and they try to pull apart features with different labels. And in the absence of source features, they are using the weights of the classifier to define the prototype. And the other technique, this one, ADSDA, is based on the information contained in batch normalization layers, and they try somehow to normalize the target data by using the mean and variance contained in the batch normalization layers. And it's also supervised with a pseudo label, which is a mix between the prediction from the source model and the target model. So in terms of results, that we use two public datasets, which are GLASS and Chameleon, because they contain image level annotation and pixel level annotation. So GLASS is a dataset for colon cancer. So there is few images, less than 200, while for Chameleon, it's a very huge one, little bit less than 50,000 images, and it's for breast cancer. So here we are in a setup that is very somehow complicated to do the source-free domain adaptation because it's for different organs, different staging, and different size for the datasets. So when we are doing weekly provide object localization, we have access to two models, one which is the best for localization and one which is the best for classification. So for this one, we try to adapt the model which is the best for localization from chameleon to glass and from glass to chameleon. So what we can observe here with the red rectangle here, so when we are doing the adaptation from chameleon to glass, we increase the accuracy of the classification by 20%, while when we do the adaptation from glass to chameleon, we just increase the accuracy of the classification between 2 and 8%. So the first thing here, it seems to be more complicated when we are going from a smaller dataset to a huge one, when we are performing source freedom adaptation. The next thing here is we try to adapt the best model for the classification. So here we do the adaptation from chameleon to glass, and we can observe different things. So the first one here in the green rectangle here, when we are doing the adaptation from chameleon to glass, we increase very goodly the performance for the classification. We are something close to 97% accuracy after adaptation. But what we observe in the red rectangle here is the accuracy of the localization decrease. So in the context of WSOL, what we observe is we can increase the classification, but the localization decrease. And the next thing that we observe in the blue rectangle here, there is an important difference between SHOT and the other technique. So with SHOT, we have 90% accuracy after adaptation, while for others, we have like between 61 and 71. The reason of that is for all the methods, they are based on pseudo labels. But in the case of SHOT, they also use the prediction of the model. And what is happening in this setup is like the accuracy of the pseudo label, it was like around 35%. So this is why one of the reasons that all the methods perform poorly, while for SHOT, the accuracy of the pseudo label was exactly the same, but the accuracy of the source model to predict was very high. So this is the reason why it's working well. So just in terms of visualization here, so we did the adaptation from chameleon to glass, and we adapt the best model for localization. So what we observe here after adaptation, we have two main things, which is under activation. So just a small part of the ROI is activated, or we have like an over activation. So a large part of the image is considering at the region of interest, which is absolutely not the case. So this is one of the problems that we have with source freedom adaptation in weakly supervised object localization context. So just to summarize quickly, there's 4 main points. So the first one is localization accuracy doesn't necessarily increase after the adaptation. It's better to use the best model for classification instead of the one for localization to perform source freedom adaptation, at least for the classification. And it seems that the methods perform well when the target domain is more than the source one. And the last thing is a limitation of method were essentially based on pseudo labels such as like SFDA, CTCL, or ADSD. So thanks everyone. I have a poster and the code is public, and we implemented like a lot of techniques for weakly supervised object localization and source freedom adaptation. So you can reproduce everything. Thanks.
Any question? Alexis, since you are here, it was interesting that the first presentation we heard, it was also for domain adaptation, supervised domain adaptation for histology images. And there was, you know, some supervised clustering on triplets and trying to. Do you think that such there can be both can improve something on your?
Yes.
I think it's interesting to see how the presentations should relate.
Yeah, most of the method are using like spherical k-means or k-means to do the pseudo labels, but I think right now there is like techniques such as DB scan that can be more useful to perform the pseudo labels, because those papers were published like in 2021, 2022. So I guess like spherical k-means was somehow famous to do that, but I think right now we can use like DB scan or GMM to do pseudo labels.
Okay, thank you very much.
Thanks a lot.
We move to the fourth presentation of this session, which the title is a multi-scale interpretable DL model for classification of mass margin in digital mammography. It will be presented by Julia Wang from Duke University. Thank you, Julia. There is a name for the technique, but you will tell it. FPN, IA, BL. Yeah.
Is it mirroring right now? Or?
Yes, it's
oh, could I change it to?
If you want, sure. Maybe go to settings.
Yeah. Wait. Just there.
There has been some question from the audience about how the workshop and session will be recorded and published, and how they can access the recorded presentation slides. We have been said that CVPR will be publishing the recorded session sometime after the end of the conference. So this is our response. Please have a look after the publications of CVPR so that you can follow if you like more of the recording. Thank you.
Is this big enough? Yeah. I don't know if it's downloaded.
Yes, I downloaded it.
It is? Okay.
Can I try?
Yeah, spoiler alerts.
Sorry, but
There we go. Great. All right. Well, good morning, everyone. With that, my name is Julia Yang, and today I'll be talking to you about our work on FPN IAIABL, which is an interpretable deep learning model designed to classify mass margins in digital mammography. And to kick us off, we're going to first take a look at some of the components that motivated our work. And the first component was screening mammography. And screening mammography plays a really crucial role in the early detection and diagnosis of breast cancer, and has contributed to a 42% decline in breast cancer death rates over about the past 30 years. And secondly, there's also a lot of interest in using machine learning and computer vision to improve these screening programs. However, there's a significant roadblock in applying this research in a way that doctors can use and trust. And that roadblock is that a lot of this machine learning is black box or uninterpretable. And without interpretability, it's not easy to know when the models might be making a mistake or maybe using confounding features. And there's a rightfully low amount of trust in black box AI models in the clinical space. To address this, our lab previously designed a model called IAIABL that explained breast cancer predictions in a way that was easy for doctors to understand. This was based on an interpretable approach that also was developed by our lab called This Looks Like That. However, when we look a little bit closer at where this looks like that in terms of an activation map, we get a very large region that gets highlighted. And this is a problem, a little bit of a challenge, because one of the most cancer indicative features is its mass margin or its edge. And we need our model to be able to focus on that margin. Additionally, for margins with sharp edges, like this circumscribed one here, we need it to be able to distinguish a very narrow region, but we need a much wider region to distinguish the wide spikes or long spikes of speculated margins. Thus, we need our fourth element that motivated our work, better localization at different scales. And spoiler alert, our new model, FPN IAIABL, does just that. As you can see, comparing the prototype activations of our new model in the middle column here to the ones on the right from our old model, the the new model activates specifically on the parts of the margin that are most important to the classification. So the big question then is, how did we do it? And to answer this question, we're going to first take a little step back to where we started, which was the initial model, the predecessor model. And in the predecessor's architecture, we first had our input image X, and we sent it through a series of convolutional layers to create a latent representation of that image. Then this gets compared using L2 distance to learned prototypes, which represent relevant aspects of the class. That's what the prototypes are for. And this comparison produces activation maps, which are each converted into a similarity score that is fed into a final linear layer to give us our class logits. This way, we are able to compare our new image with known cases that we've seen before to get an explanation that doctors can understand. However, as we saw in the previous slides, this produced prototypes that were a bit too diffuse and non-specific for our use case. And to address this issue, we looked to another popular architecture in computer vision, the feature pyramid network, or FPN for short. And the novel contribution of the FPN was that it extracted features at multiple points in the model, which provided information at multiple spatial and semantic scales. So we were wondering, what if we could take this FPN model and apply it to our previous structure to make prototypes of different spatial and semantic scales? And that's exactly what we did. We took the FPN structure to produce multiple feature maps at different spatial and semantic scales and applied it to the previous model. However, the important part here is that for the prototype layer, each prototype is configured to come from a specific part of that pyramid, a specific layer in that pyramid. So each prototype is also going to be at a specific spatial scale. In other words, we can configure our prototypes to be localized. And I wish it had been as easy as just taking these two models and putting them together, but because of the complexity of the model, the small data set that we were working with, as well as the intentional constraints of interpretability, we needed to make a few extra adjustments to our model. The first adjustment was that we adjusted that L2 similarity score to a combination of cosine as well as focal similarity. The second one was prototype replacement, and the third was negative class prototypes, which you can read more about in the paper. And lastly, we adjusted the loss function to include these five different terms. The first term being cross entropy, which encourages classification accuracy. The next two terms encourage a clustering structure in the latent space to make distances more meaningful. And then we have orthogonality, which encourages the prototypes to cover different aspects of their respective classes. And lastly, we improve upon the fine annotation loss that was introduced in the predecessor's model, but had some extra improvements to it for our new model. And we're going to dive into this last term a little bit. For fine annotation loss, a small number of images were labeled pixel-wise to help the model highlight the exact areas of the margin that are most relevant to its class. The fine annotation loss then penalized the model for activating outside of that highlighted region. However, for one image can contain multiple margins. For example, in a lesion like this spiculated one, in the fine annotation is just the highlighted spikes on the margin for the spiculated class. But there's a whole other part of the margin that's unhighlighted that looks like it could be indistinct or circumscribed. So we don't want to necessarily discourage our model from having an indistinct prototype from activating highly on that unhighlighted region. So in our model, we introduced fine annotation coefficients customized for each pair of classes such that they can be encouraged or discouraged from activating inside or outside of that highlighted region on a class-by-class basis. And this significantly improved the results. And speaking of results, let's dive into the results. So our model was able to maintain a high classification performance and, as we saw before, does a much better job at activating only on the most relevant areas of the mass margin for classification. On top of that, when we configure the model to constrain the prototypes to specific FPN levels, It can learn prototypes that activate at different spatial scales. Prototypes from the lower FPN levels, like level 2 on this side, activate on the smaller details of the image, while higher FPN levels activated on the larger areas of the images. So for the circumscribed class, the smaller scale prototypes best represent the hard edges, here on FPN levels 2 and 3. And for the spiculated class, the smallest scale is not very useful, but FPN levels 3 and 4 capture the most relevant concepts. So with these results, what are some of the main takeaways? Well, first, because now we have our configurable multi-scale prototypes, we open up a whole new realm of ways to apply interpretable models to different applications. Also, the interpretable models provide faithful explanations that clearly indicate the specific areas of the image that contribute to its classification, and we can better calibrate our trust in these models. With this, we now have a way to take some of those really cool computer vision models and apply them for breast mammography and get that much closer to being able to take them into the clinical space. So with that, I'd like to thank the rest of my Duke interpretable mammography team that helped me with this paper, as well as Lars Grimm for data labeling, and 2 other folks for their code contributions. And again, my name is Julia Yang. One of my co-authors, Alina and Jade Barnett, is in the audience with me, and the QR code for our lab is on the screen. Thank you.
Papers, this looks like that. We give it to the students to review.
Nice.
Report. 2 questions. First, about orthogonality. Is it per class, per layer, or across all? So what do you do in case in different layers some similar overlapping patterns emerge? And the second, how easy it is to apply on new data, so to train the model from scratch, because we know Protopeanut was relatively harder to implement for other data sets.
Yeah, those are both very great questions. So the first question was orthogonality. Is it measured on each level, or is it like across the entire class? Okay, and then the second question was domain adaptation kind of things. Third question, is the code available? Okay, so for the first question of orthogonality, how is it applied? So right now we have it per class, but I think theoretically it should be for each level because they're different latent representations at each level. So it should be at each level. We have orthogonality compared. And then for your second question, for domain adaptation, right? Or like applying it to different data sets. So we're working on some more research on that front to see how we can apply it in different fields as well. And then the third question, sorry, I'm running through these quickly. The third question was code availability. Yeah, feel free to email either Alina or myself, and we'd be happy to share the code with you. It's in research level code, so yeah.
Okay, thank you very, very much.
Absolutely, thank you.
Sorry.
Oh.
Yes. Last question. Yeah, last question. So, Arvanik says, hi, great presentation. Thank you. She works on a similar topic. So could you please let her know if you use enhancement on the images and how that affected the results?
If we use enhancement on
the images.
The images. Yes, we do use augmentations. So I don't remember them off the top of my head. If you're curious about the specific ones we use, you can definitely email me and I can send you that piece of code. Yeah.
Thank you very much.
Thank you very much.
Thank you.
We have to get a bit fast now because we have the first invited talk in some minutes, and the last presentation of this session will be virtually because Sidva Alem could not take her visa in time, but she is with us. The talk is test time adaptation with SALIP. SALIP is a cascade of segment anything model, everything model, plus clip for zero-shot medical image segmentation. So it's an interesting topic. We face it now more and more. And Silva Alem comes from Dublin City University. And
What's the ID 70?
70. Yeah. So we have the
video, yes.
Video presentation, and then
Hi, everyone.
we can ask.
My name is Sidra Alim. I'm a
One moment, some technical difficulties. Let me try different.
Hi, everyone. My name is Sidra Alim. I'm a final year PhD researcher at ML Labs in Dublin City University. I was supposed to travel to CVPR in
If there's a problem now, will you fix it?
Yeah, maybe we can.
We can move now to the because Ronald is waiting. Because Ronald is waiting for the
Invite talk.
for the first invited talk. Maybe we go first to Ronald and then.
Okay, until I fix it, yeah.
Sorry for this, Silva. We will come back in very soon. And so, Ronald, can you hear us?
I can.
Okay. Sorry. Give me a minute to introduce you, okay?
Okay.
It's our great pleasure to have with us Ronald Summer, and we will present the invited talk on automatic extraction of biomarkers through deep learning and explainable disease diagnosis.
Can you hear me? For some reason, I cannot hear you anymore.
Can you try again?
Yes. Can you hear and see my slides?
Yes, we can.
Okay, so the floor is yours, and
okay.
Please.
Great. I'll get started. Thanks so much. It's a great pleasure to be here today. I'm going to talk about automatic extraction of biomarkers through deep learning and explainable disease diagnosis.
One moment, Ron.
Just one moment,
The
because
sound is not transmitted very well. So I think it should be something there.
Ron, can you try to speak again to see if we can hear you now?
Sure. How is it now? Any better?
Is it better now?
How does it sound now?
Can you try one more?
Can you try speaking in so that we can check?
Sure. How's the audio now? Any better?
Better, right? Okay, yes. Now it's working fine. Yes. Sorry for that. Stage is yours.
No worries. Okay, thank you so much. It's a great pleasure to be here. Thank you. These are my disclosures. And the work I'm going to present in this talk today was done at the NIH Clinical Center, shown here. This is the world's largest hospital devoted entirely to clinical research and provides free patient care for patients enrolled in clinical trials. So if that's something that you might be interested in, you can check out some of the trials that we're doing at clinicaltrials.gov. So today I'm going to be touching upon the topics of interpretability and explainability. And in the paper shown on the slide, led by Mauricio Reyes, we put forth some ways to improve interpretability of AI in radiology, including explanations through visualizations, explaining through counterexamples or influence functions, explanations through semantics or text descriptions, and uncertainty estimates of machine learning models. But in our research, what we found to be most helpful is simply to provide visual segmentation results and quantitative metrics on regions of interest that can be easily replicated by a human to ensure reproducibility and explainability. And so I'm going to run through many different applications of this perspective on using explainability in radiology AI. And what you're going to see in this talk is a constant theme where we're going from organ segmentations to disease predictions. So as we go along, you'll hopefully see that theme. And I'm going to start with one of the areas that we've focused on the most in my group, which is the investigation of body composition and how it relates to disease. For those of you who might not be familiar with the concept of body composition, you may be more familiar with just measuring body weight or waist circumference, body mass index, or lean muscle mass. These are all easy ways to assess body composition, including the amount of fat in our bodies and also the amount and quality of muscle in our bodies. And these body composition metrics are called surrogate biomarkers for health and risk of disease. While they don't necessarily directly relate to diseases, they can be highly associated. So I think many, if not most of you in the audience know that folks who have obesity are at greater risk of things like cancer and heart disease. And these body composition metrics are playing an expanding role in clinical research and practice. So over the last more than a decade, I've been collaborating with Perry Pickhardt, an outstanding abdominal radiologist at the University of Wisconsin-Madison, on a series of large-scale body composition analysis studies. We've published over 30 clinical papers together on this topic using AI, and I'm going to tell you about the 5 AI tools that we're using in this research, and these AI tools are being continuously improved in our groups. The 5 tools that form the core of this research are shown on this slide. The one in the upper left is a tool that identifies the abdominal aorta on CT scans. The abdominal aorta is this cylindrical structure here on this coronal CT image through the abdomen. Just to orient you, these are the 2 kidneys. This is the aorta, and these are the pelvic bones here in white. And these white vertically oriented things are the calcified atherosclerotic plaques in this organ, which develop in all of us as we age. And on the right here, the red marks are the AI superimposed segmentations on these plaques. The second tool, AI tool, shown in the upper right, this tool segments the liver, which is this organ here, and measures the average CT density of the liver. In this case, it's -13 Hounsfield units, which is inappropriately low and indicates fatty infiltration. So you may not be aware of this, but in certain conditions like alcohol use, certain conditions like obesity, and also diabetes, the liver can become fatty, and on a CT scan will look dark like this liver. The third AI tool that we developed is one that segments the muscles in the abdomen. In this image through the abdomen, you can see a little bit of the kidney here, and the large and small intestines are these structures here. This is the spine, and the red is a segmentation of the muscle by this third AI tool. I'll talk about how that's useful in more detail momentarily. This is the fourth AI tool that we developed. It measures the bone mineral density. This is an assessment of how weak the bones are, to put it colloquially. The lower the density, the CT density of the bone marrow shown in this region of interest here, it's 128 Hounsfield units. The lower that measurement, the more at risk the patient is to bone fractures. And women are affected by low bone density or osteopenia or osteoporosis to a greater extent than men. That has to do with the effects of sex hormones. And in the lower right is two images of the fifth tool, and that's the one that measures fat, both internally, shown in blue, that's called visceral fat, and the fat under the skin, that's called subcutaneous fat, shown in red here. One other thing I'll point out about these different images is that they all are used in what's called the opportunistic screening mode. The idea there is that the patient has come for a CT scan for some problem, be it abdominal pain or colorectal cancer screening, and the AI tool uses the exact same data without any additional scanning or radiation exposure to make all these measurements and inform the patient of various risk factors that they might have and not be aware of. What we did was we took these 5 opportunistic screening AI tools shown here, and we ran them on about 9,000 CT scans and compared the numerical outputs of these tools to various outcome measures like cardiovascular risk and overall survival. And this work was published in Lancet Digital Health a few years ago. What we found in that study was that the AI tools outputs were pretty good predictors of overall survival. These are ROC curves on the left and right, and they show the performance of the AI system for aortic calcification, muscle density, and a combination of aortic calcification, muscle density, and liver density at predicting overall survival with a multivariate AUC of 0.811. Now, in comparison, when we looked at those traditional body composition metrics like Framingham risk score and body mass index, neither of which require any scanning or invasive techniques, the highest the AUC could get was 0.688. So you can see better prediction from the AI system in combination with the CT scanning. And here's an example where such prediction might be useful for an individual patient. This is a 57-year-old man. He was undergoing colorectal cancer screening with CT colonography, also known as virtual colonoscopy. He had a high amount of visceral fat, shown in blue. He had a very low liver density of 28 Hounsfield units. This should be up in the 60 to 80 Hounsfield unit range if it were normal. This man had plaques, calcified plaques in his abdominal aorta with a very high plaque score. In this case, it was over 5,000. And 12 years after this original CT scan, this man had another CT scan, and he had even more plaque in the aorta, more fat in the liver, more fat in the visceral fat area, and he had lower muscle density and higher muscle fat. And this man died shortly after this CT scan. I mentioned that one of the 5 tools assesses the muscle in the abdomen, and what you see in these 2 slides are 2 different patients. The patient at the top has normal muscle quantity and normal muscle density The muscles, again, are this gray tissue here. This darker gray is fat, and then the black areas are air inside the bowels. And if you compare this person's muscle to this person's muscle, you'll see this person has less muscle, and the muscle has fat interdigitated between the muscle bundles. So this is poorer quality muscle and lower volume of muscle. So lower muscle volume is called myopenia, and a lower muscle quality due to fat interdigitating between the muscle bundles is called myosteatosis. And as I'll show you, an individual that has myopenia and myosteatosis is at risk of a number of bad health outcomes. And the first of these is osteoporotic fractures. So this is a 59-year-old asymptomatic woman. She underwent a CT scan for colorectal cancer screening. She had a very low bone mineral density, only 63. This should be over 140. This is her muscle. It measured negative 1.7 Hounsfield units. This should have been maybe 30 or 40 Hounsfield units. And 3 months after the CT scan, she fractured her left hip here. This is the fracture area. Just to remind you, the patient's right side is on the left side of the image and vice versa. Now, one interesting thing that you could do with such an AI system is assess the bone mineral density and muscle quality on all the CT scans that an individual has had over their lifespan. And if one had been able to do that, one would have seen over the preceding 12 years that the muscle density started out at 135, just mildly osteopenic, and over time degenerated into the osteoporotic range until she developed this fracture. And if this loss of bone mineral density had been known, it's possible she might have been treated with drugs that can reduce the risk of these fractures. When we look closely at the muscle quantity and muscle density, we find that the key attribute is actually the muscle density. If you have fat interdigitating amongst the muscle bundles, you're much more likely to get a hip fracture. And this is a Kaplan-Meier curve showing 150 months of follow-up after CT scanning, and patients in the lowest quartile for muscle density were at very high risk with a cumulative incidence of around 7 to 8% of having a hip fracture. Time to death was also increased in people who had fatty muscles as well. And muscle volume seemed to be less differentiable between people in different quartiles. Now, we looked more recently at this issue of myosteatosis, or fat within the muscles, and we found that individuals who had the highest quartile of fat within their muscle had a hazard ratio of 4.3 for increased mortality. And as things go in predicting future outcomes, a hazard ratio of 4.3 is a substantial risk. And again, when we looked at muscle quantity versus muscle quality, we find that the muscle quality is distinguishes much better the risk of dying compared to muscle quantity, as shown on the left set of curves. The examples that I showed you of muscle analysis were done mainly in the abdomen, but it can also be done in the chest. And this is an example of a study we did on a group of women who suffer from a chronic lung infection called non-tuberculous mycobacterial disease. And what we found was that the same issue, that women who had lower density muscles because there was more fat within the muscle tend to have poor outcomes with this chronic infection than those who did not. So this, there's been quite a bit of research showing that the assessment of muscle can be very helpful for a number of different important clinical outcomes. For example, our group has looked at patients undergoing liver transplantation. Other groups have looked at patients undergoing various types of surgery and chemotherapy for different cancers. So the amount and quality of muscle turn out to be important factors, particularly the quality of the muscle. And because of all these findings that we and others have made showing the importance of muscle and other research showing the importance of fat distributions, we've been improving our muscle and fat segmentation algorithms so that they work throughout the entire body, not just in localized areas like single slices in the abdomen, which has been the traditional way of assessing body composition. And this is work from Jean-Fei Liu and my group presented earlier this year at SPIE, looking at different methods for improving muscle and fat segmentation. In this case, the muscle is pink and the fat is yellow for the subcutaneous fat and blue for the internal body fat. And he's extended this work to the chest and the pelvis, two relatively understudied areas. And one of the areas that requires some improvement is the misinterpretation of breast tissue as either muscle or fat. And so there's some of the work that he and other members in our group are doing is improving that differentiation. Many of you in the room may be familiar with Total Segmentator, a very popular publicly available automated tool for segmenting over 100 structures in the body on CT scans. We did a comparative analysis of our muscle and fat tools to the ones in Total Segmentator and found that our tools were superior to theirs on manually labeled data. And that was work led by Benjamin Hu, a former postdoc in my group, presented at CARS actually later this week. There are many different applications to body composition. I'll show you a bunch of other ones. This is the segmentation of edema. Edema or swelling is an important thing that occurs in people who are sick because of either liver, kidney, or heart failure. You may be familiar with family members or friends that have, for example, ankle swelling because they might have heart failure or some other organ failure. And this type of edema or swelling can occur throughout the body and can cause a lot of the fluid in the body to be displaced or third spaced is the medical description for it into places like the subcutaneous fat. So what you see here is a CT slice through the body at the level of the junction of the abdomen and the pelvis. This is part of the pelvic, one of the pelvic bones. The patients in the scan are a little lopsided, so we only see the left pelvic bone. And here's the spine. And all this gray stuff here, sort of intermediate gray, that's swelling in the fat. The fat should be much darker, should sort of look like this fat here. And this is a segmentation of that subcutaneous fat. And we're in the process of measuring that fat and then determining clinical utility in patients with the diseases that I mentioned earlier. Another approach to explainable AI for radiology that we've taken is bounding boxes and probability scores. This is work done by a former postdoc, Shuai Wang, and published in Medical Image Analysis a couple of years ago, shows different lymph nodes in the abdomen that are being detected by his AI system. His software puts a bounding box around the lymph nodes as shown in these three examples, and then a probability score as shown in the red text. And that may prove helpful in certain circumstances for explainable AI for this application. And we've been expanding that explainable AI to look at a variety of different MR pulse sequences, including T2 fat suppressed and diffusion weighted imaging, as shown in this work from Tejas Mathai, a staff scientist in my group, published at CMIG a few months ago. I mentioned Total Segmentator, which is very useful for segmenting anatomic structures in the body on CT scanning. You can do something similar with MRI, and Yang Zhuang in my group, a current postdoctoral fellow, showed in a paper in CMIG how to do something similar for pelvic MRI using synthetic CT images to map Total Segmentator. total segmentator-based analyses to MRI scans. I'm hearing someone speaking. Can you hear me okay? I'll just continue.
Great.
And Jan has been using different synthetic image generators shown here. This is the ground truth segmentation. You can see some of the older synthetic GANs in these three middle columns, and the one that he's been working on, SynDiff, on the far right columns, showing segmentation of things like the bladder, the hip bones, the gluteal musculature, as well as other organs. And his technique involves doing MR to CT translation to create a synthetic CT, running total segmentator on the synthetic CT, developing segmentation masks, and then that's for organs and structures. For musculoskeletal masks, we take the MRI volume, register it to a misaligned CT volume in patients who have had both CT and MRI, applying total segmentator, creating segmentation masks, doing manual correction, and then doing active learning rounds from 30 to 100 to nearly 800 subjects to develop the final segmenter. And you can find his paper on arXiv using the identifier shown here. And his method applied to abdominal MRI works very well with high Dice coefficients. I'll show you those in a moment. But you can see the different bones in the spine, the ribs, some muscles like the psoas muscles and the back muscles. Here you can see some blood vessels segmented. Here are bowel, including stomach and duodenum. Here are various organs in the abdomen on the far left. And this technique works very well on MRI, even in the setting of disease. For example, this patient has cancer in the liver, but the segmentation is fairly accurate. This is the automated segmentation on the bottom. This is the ground truth. Here's a kidney with a big cyst, accurately segmented, and you can see other examples of the spleen and stomach and some bowel here. And these are the Dice coefficients for this technique, ranging from high 90s to mid 90 percentiles on dozens of different organs. I'm now going to switch gears and talk about a different organ, the pancreas. This is the pancreas on a CT scan of a normal person. You can see the pancreas is relatively homogeneous in density with smooth margins. And on the right, you can see that this pancreas is lobulated and heterogeneous in density in this patient with diabetes. And what we found was that simply by measuring the density of the pancreas using an AI system, we could predict up to 7 years in advance whether a patient would develop diabetes, because over time, a person with diabetes has a pancreas that gets lower and lower in density, as shown in these examples, ranging from normal to longer durations of diabetes. The same technique with explainable AI works in the liver. This is a project done by Sungwon Lee, a former postdoc in my lab, who's a radiologist now working in South Korea, in Seoul, South Korea. And she developed an explainable AI system that identifies the different parts of the liver and showed how, as the liver went from normal to cirrhotic or fibrotic, this part of the liver here, shown in red and orange, started becoming bigger, as you can see here, and the parts shown in green, blue, and purple started getting smaller. And this technique matched very well with biopsy results on these livers at predicting how much fibrosis they had. Similar techniques can also be applied to the abdominal aorta, as shown here, for detecting aneurysms like this one in the abdomen, and for detecting lesions throughout the body. For example, in this universal lesion detector presented at MICI back in 2018 with bounding boxes and probability maps on lesions in the chest abdomen and neck, for example. And these sorts of techniques can also be applied to transient phenomena like kidney stones. This is an example of work from Pritam Mukherjee in my group, who looked at over 370 kidney stones and was able to track these stones, measuring their volumes and growth rates over time using an AI system. The last example that I'll show you before I conclude is on small bowel analysis. The small bowel is one of the most challenging organs in the body to segment and to find disease because it's a lengthy structure. It averages about 22 feet in length, and it's also tightly coiled in the abdomen in such a way that the bowel loops touch a variety of different organs and they touch one another, making it very hard to segment. This work, led by Sungyan Shin, a former postdoc in my group, presented at MICI in 2020, used topology and a cylindrical constraint in an AI system to segment the small bowel. He then improved it in 2021 MICI by adding methods to disentangle intensity and non-intensity features with a two-stream autoencoding architecture. And then at MICI in 2022, he showed how he could track the small bowel throughout its length by using reinforcement learning. And finally, last year in 2023, in a paper in Medical Physics, he showed how he could use his method to identify a very small cancer of the small bowel called carcinoid tumor, shown in these bounding boxes here as these bright spots within the small intestine. So those are the types of explainable AI that I've been developing in my lab. We've tried to focus on the abdomen with a few examples in the chest and elsewhere in the body. I think there are lots of roles for other types of explainability in AI. We heard about some of that from one of the earlier speakers in this session who was looking at breast cancer. And I think this is an exciting area of research that is progressing quite rapidly. The work that I showed you in this presentation was done by the many members of my group. Here's some recent members of our group. I'd like to acknowledge our different funding sources and training programs. And I encourage you to reach out either by email or by checking my website or our lab's GitHub site to find downloadable code and data and learn more about some of the work that we're doing. So that concludes my presentation. It's been my pleasure to speak to you all, and I'd be happy to answer any questions.
Thank you, Ron. There are some questions. We'll go through them. The first one.
Thank you, Ronald, for the great presentation and a lot of content. This is Vikas here. The question is, a lot of density-based analysis, like HU-based analysis, are also dependent on the machine and the filters used in the machine. So have you studied or any of the algorithms where you kind of observed the differences in the HU analysis just because of the machine that was used for the imaging versus the algorithm?
Right, right. So if I understand correctly, you're asking about the effect of different scanning protocols and machines and other acquisition parameters on the density metrics amongst others. Did I get that right?
Yes, that is right.
Oh, okay. Yeah, we have looked at that. For example, we have done a series of experiments looking at the effect of intravenous contrast and on these different density metrics. We've also we've looked at different scanner types and manufacturers and slice thicknesses. For example, we did a published study where we looked at what are called outside CT scans. These are scans from different hospitals that get loaded into your hospital's PACS archive. And the particular study that we did had scans from over 700 different institutions, and the outputs of the AI algorithms were robust, particularly for the density measurements.
Okay. Is there another question? Let's see any other questions. Ron, maybe I can ask you, what are your expectations? Which there are a lot of large models, whether they are vision language models. Do you think that they will contribute to explainability in your future work?
Okay, so if I understand the question, you're asking about the large models like vision and language models, and if we see a role for those in our work. Did I get that correct?
Yeah, correct.
Yeah. So we are exploring them. For example, we did some work recently with large language models on radiology reports, and found ways to make the outputs reproducible. The explainability is a little challenging, but if you can craft the nature of the task so that it's very well circumscribed, you can get very high performance and very little variability in the large language model outputs. For visual language models, we've done less work. This is, of course, a very exciting area, but we are starting to get into that area. For example, we've just had some work accepted for publication looking at visual language models on exam questions, and we found that under certain circumstances, these vision language models work pretty well. But I think the explainability challenges will be a whole order of magnitude greater. I think one of the challenges is if you do the sort of explainability that I showed in this presentation, it's very easy for the radiologist to understand how we're getting from the AI output to the prediction, and it becomes very challenging to do that with something like a visual language model.
Okay, thank you very, very much, Ron. It was a great pleasure to listen to all this work you have accomplished, and we are looking forward in the following in the next works. Okay.
Fantastic.
Thank you for us, and hope to see you soon again. Okay.
Thank you so much.
So now we have to get to the normal presentations. Can we go to the
Yeah, so let's go with Sidralim now that we didn't see before.
Now we'll start with some presentations on some models. That means, I think there will be at least 3 presentations on some models. Okay.
Yes.
I was supposed to travel to CPR in person, but unfortunately, issue that was not able to today. So I will be presenting my work to all of you online, and will forward to any feedback or questions that you have. So the research is complete. A paper titled Adaptation by Adapted and for View Short Medical Recommendation. So with the overview and recommendation, I'll be starting with introduction and contribution, and then we'll be so that brings us to the presentation that information models be adapted to medical images during research. Research paradigm has been completely changed now to recent, and it's important to evaluate their applicability. So this is the motivation behind our research. The first is that this is a foundation model that we are trained on projective. And many of the very subpractices when they are directly applied to medical imaging. The second is prompt engineering, because prompt are very integral part of this foundation model. There is prompt engineering domains for these are required, which are not very readily available in medical. And the third one is adaptation, which typically involves in scientific, but in medical meaning there is scarcity of data set, and these models are huge, so when we have limited data set to train or fine tune this model, it leads to overfitting. So the proposal to overcome these challenges change the scale of standard people in a short metabolic application. So we start with passing the input image along with the grid of point prompts to scan everything there, which yields a pool of region proposal in the image. Our objective is to use these region proposals to crop the input image and then get the relevant crop that corresponds to ROI, which is youngest in this particular case. But before using these region proposals to generate crops, it's important to highlight that there could be some instances where a region proposal contains ROI, but it's not ROI. So in this particular case, like for instance, one of the region proposals that was generated by Sam was the background. And if we have a background region proposal and we use it to create a proper image, it would be the image itself. And in this particular case, the input would be having a whole of the lines. So it's important to highlight that in such cases, it can lead to misclassification. So to mitigate these issues, we perform an area-based threshold where the region proposals that have area beyond a certain threshold, they are discarded. And eventually, the rest of region proposals are used to create the crops of the input image according to the respective region proposal. Now, the next step in the pipeline is to use clip to retrieve the relevant region corresponding to ROI. So these props, along with the text prompts generated by ChatGPT, are fed to clip, and then eventually we simply perform a top K operation in order to get region of interest. Here we perform a top two, we got top two scores because we have two regions of interest left and right now. And eventually mask the crop is used to create prompt in that particular region in the image. Eventually, these box prompts are used to prompt SAM promptable segmentation mode. And along with these prompts, the input image is fed to SAM promptable segmentation mode, which eventually leads to the segmentation mask. So now I'll be talking about the contribution to the work with the first one unit that we propose is simply framework that harnesses SAM for user thought segmentation. The second, being the visualization of both SAMs, SAM editing mode and SAM practical segmentation mode. The existing methods have been using some off-the-shelf models to create prompts for SAM, which needs training, and eventually they also need prompt engineering. And third one is that SAM is completely adapted at test time, and it's completely training in fine-tuning, which means that it has no computational constraints. And eventually, when you call these foundation models, you are able to eliminate the need of prompt engineering and domain knowledge. So now I'll be discussing about the results. And we really have method on 3 diverse tasks. One is brain segmentation for manual scans, the second one is brain segmentation for chest X-ray, and the third one is brain segmentation for ultrasound intelligence. And the column on the right hand side shows our results as score is our respective evaluation method. And if we compare our results with the uncopied version of SAM, there is a huge performance improvement. And even if we compare our method with GTC, the ID forms are extracted from the ground truth. Even then, for all three modalities, our performance is quite close to the GTC. So that shows the strength of our very short time.
So here is the qualitative comparison of with solid with other techniques to explain anything that's solid very well associated to the others, and also it has close similarity with the ground truth marks. So that is from my side. You can go to the paper, post of any edition, I'm taking questions now, but in case of any issues, one of my is there, Thank you.
Thank you very much. Is there any question?
Actually, I have a question. So, Sidna, thank you very much for the talk. So, in your methodology, you have prompting LLMs in order to give you some, let's say, information regarding the images. The question is, did you, because generally, you know, LLMs are known that if you ask them in a different way, they can give you a completely different task, a completely different aspect, and generally, they have hallucinations. So the question is, if you have used some prompting, some different prompting methods while you were asking them. And the second is, if you have verified with any medical expert the output of the LLM, of ChatGPT, for instance.
Okay, so for the second one, it's very difficult to find some experts, so that has not been validated for now. But for the first one, your question was, if I'm correct, you asked that the sensitivity of LLMs to prompting, right?
Correct,
This
yes.
questions. Yeah, so we had faced challenges for that, but as I got this approach of creating the visually descriptive sentences for the region of interest, it has been validated on natural images. So that's what that's the paper that is published already in ICCV. So we followed that particular approach in our case. But in order to bring more improvement, we tried out different visual prompting technique as well. But at that time, they were not working very well because clip specifically, it's extremely sensitive to spatial alignment, specifically when there are multiple region of interest like left and right lung. So those kind of techniques did not work well for our particular studies with Saleh, but eventually in our future work, we'll be focusing specifically on that.
Great, thank you very much.
Thanks.
Any other questions? Okay.
I think we should.
Yes, we can move on. Thank you again.
Thank you.
Okay. Now we are going to I think there are 8. Okay, there are 8 short presentations, and this we'll get through this through the short break. Then I think either the persons who have to upload the posters can go to the poster session if they have the colleagues can do that. So these poster presentations can also be found in the poster area. So you have the time afterwards to have some discussion if you like to go through the poster area with the respective person to find them there and have more discussion of them. So there are now some short presentations, and we'll start with how some, it's again about some segment anything model, perceives different MRI brain tumor domains. And this is from Cecilia Jan Alberta from the University of Autónoma de Madrid, UAM. Can we go through that?
Yes.
Thank you for working with me. I'm part of the Physics and Lab Research Group from the Autonomous University of Madrid. Now we present a paper how some perceive different MPMRI brain movements. You can access the source code using the QR in the upper left corner. Typically, models for semantic segmentation run on 3 channels. When applied to single segmented images, this is treated to fit the network. However, brain MRI images come in 4 channels, which radiologists employ jointly to diagnose. As we can see in this image, a single modality for adult glioma does not always capture the full extent of the tumor, and the same issue occurs with other brain tumor groups. Our main contribution is taking SAM's architecture and just modifying its encoder to process 4 MRI modalities. We adapt and train only the pulse-embedding layer to receive 4 channels instead of 3, keeping the rest of the parameters frozen. Secondly, we duplicate the attention mechanism applied to extract embeddings. We establish spatial level attention in the original pathway and left level attention between slices of the same MRI in the new pathway, combining both of them afterward. Finally, we incorporate medical-specific knowledge into the network using LoRa blocks. These blocks are the only training parameters apart from the pulse-embedding layer, representing 3% of the total network parameters. Analytically, using all 4 MRI modalities improves results across all cell types comparing to treating a single modality or combining 3 of them without modifying the model structure. In this image, we saw 4 examples where our proposed model detects the presence of the tumor, while models trained with 1 or 3 MRI modalities fail to do so. Finally, we observed that the filters extracted by SAM are not generic to brain tumors but parallel residual domains. Hence, we are currently exploring and supervising main adaptation methods to address this in future studies.
Here, present.
Just to check if Cecilia is either here in the room
from the team.
From the team.
Okay, so I don't know if is there one question if you like we can ask. Otherwise, you can have discussion on the poster area. Okay, thank you very much. Now the next presentation is on an efficient transformer architecture for 3D medical image segmentation for Seha Pereira from Ohio State University. Is Seha here?
It's a very low volume.
Which contains transferable feature output above the simple linear encoding stage. The key takeaway is that the sequence reduction capability of subcoding can efficiently extract relevant spatial and temporal features from volumetric and 3D data, and is ideal for 3D medical imaging, video analysis, and other disciplines with volumetric or 3D data. Please join us at our booth to learn more and see the qualitative and quantitative results of our approach. Thank you.
Okay, I think we move ahead. I don't see anybody here. Okay. Okay, so the next presentation is again on SAM model. So it is percubed approach for robust adaptation of SAM for full segmentation. It's from Mendy Rahman from the University of Texas Austin.
And I am going to present an exam pattern from the robust adaptation of segmented model for quality segmentation. From television models, a segment anything model for SAM, originally designed for general purpose segmentation task. It has recently been used for quality segmentation as well. However, SAM is unable to imprecise user prompts during inference. Therefore, it is critical to develop a robust adaptation method that is resilient to imprecise bounding box prompts perturbation. To address this issue, we investigate continuum of SAM, namely PP-SAM for quality segmentation with variable bounding box prompt perturbations. In the box 2, we have a pattern bounding of prompts. There are no perturbation means we extract the bounding box from the output mask, but variable perturbation on all sides means we perturb the extracted bounding box in all sides differently. Here is our results, and we can see that when we have 100 pixel perturbation during inference, our method achieves 60% improvement over if we do not use perturbation during training. For 50 pixel perturbation group, 8% improvement. To conclude, it significantly improves model resilience to bounding from perturbation during inference. For fine-tuning with limited data, PP-SAM is a better choice over even fully supervised SOTA methods. Please visit our poster for more information. Thank you.
Is Rahman here? Okay, so thank you. Is there any question for him?
Generally, if there are any questions either in the chat or here, because those are poster sessions, you can always go to the poster and speak, face to face with the authors. Thank you very much.
The next talk is titled Interpreting Code with Lateral Flow Tests Results with Foundation Models. And from Stuti Pantel from the University of Colorado Boulder.
And thank you for coming to our talk about our paper, Interpreting Code with Lateral Flow Test Results Foundation Models. My name is Josh Meristeen, and I'm presenting on behalf of my co-authors, Steve Handy, Jared Reynolds, and Donna Ferrari. As many of us are likely familiar with, lateral flow tests, or LFTs, enable rapid, low-cost testing of health conditions such as COVID-19 or pregnancy. Automatically reading these tests yield many societal benefits, such as allowing blind or low vision users or BLD users to independently learn about their health, as many tests are not accessible by design and hard to read as they stand. These readers also can accelerate data entry for large-scale health monitoring applications, cutting down on the amount of human labor that needs to happen in these processes. What we want to know is that these automated readers can yield both accurate and explainable results, which are important for when they're deployed in the real world. For this, we established a COVID-19 grounding data set that we had sent an existing data set of 325 COVID LFT test images and provide groundings for the actual testing device, so what you hold in your hand, or the end result window, so the window that indicates if a test is positive or negative. And this allows us to benchmark modern models and see how well they can be used for automatically reading LFT tests. And we benchmarked 8 modern foundation models, such as GPT-4 Vision, Flip2, and VIP Lava, with their capabilities surrounding identifying the test and result window within a generated image caption, both with no priors and with location priors, and seeing how well they can ground the test result and window, either through segmentation or through a bounding box. But overall, we find that models struggle to recognize and ground the type of test and test result, such as generating nonsense in a caption, or not recognizing not just type of test.
Okay. You stood here.
No, it's not. It hasn't finished.
Hasn't finished?
No, there is another 20 seconds.
The user is trying to describe, such as taking a COVID test for pregnancy test. despite the COVID test, saying COVID-19 on it. And yeah, thank you again for watching. If you're interested in learning more, I highly recommend you check out our paper at the depth BI workshop, or check out the link here. We do release our data set for public use and hope that as a community we could keep pushing on automatic reading of L2 tests. Yeah, thank you again.
Thank you very much. Okay, I think we continue now. The next presentation is entitled Complex Style Image Transformation for Domain Generalization in Medical Imaging. And the authors are Nicolas. Hello, everyone. And Paraskevis here, I know, from NTUA.
My name is Nicolas Panos, and I'm a PhD student from the National Technical University of Athens. I'm going to present to you in this video our work that was accepted in this year's DevAI AMA workshop at the CPR conference titled as Complex Style Image Transformations for Domain Generalization in Medical Images. Modern state-of-the-art models rely on large annotated data sets and large resources for optimized performance. In medical computer vision, the lack of data availability and the problem of domain shift, i.e. degrading performance when applying a model trained on the data set from one source to data acquired from different sources, lead to suboptimal systems. This discourages the use of AI as tools in the industry, as it cannot be expected from hospitals to have the required resources for running inference on large models.
Domain shift is dealt by using augmentation tactics such as adversarial learning and style transfer to create new out-of-domain distributions. These methods, however, generally depend exclusively on the source domain. We propose augmenting the source domain with complexity from mixing the input batches with fractal images. This leads to an augmented generated domain which covers a wider spectrum of samples. In this slide, we can see the proposed architecture. We take influence from previous work which proposed the auxiliary decoder. The decoder generates out-of-domain samples from the latent space using style transfer methods. As an extra measure, we augment the input batches with a probability of 40% by mixing with fractal images and rudimentary augmentation techniques so that we can ensure the encoder is generalized as well during normal training and that even the latent space is augmented. We can see from the results that our method increases out-of-domain distribution and remains competitive with IID without any need for more resources. In our paper, we also have more experiments done with more complex models where it's showcased that the augmentation framework leads to higher performance with more parameters, remaining within appropriate margins for practical use. The first table involves prostate segmentation data, and the second one involves corruption cardiac, so that we also present that robustness is also augmented by using such methods. Thank you very much for your attention.
I'd like to thank you for your attention, and if you have any questions, I'd be delighted to answer them. That's it.
Okay, actually there was one question on the back.
I have a question about the augmentation in the latent space. So what is it exactly?
What basically happens is the encoder portion just produces the latent space, and afterwards there's a second decoder which has style transfer layers. The layers add an intermittent a noise portion, style noise, throughout the decoder portion. It basically happens so that we don't do it in the input space because the latent space has the information much more dense and better represented. So it's better to augment from the latent space instead of just the input. But we wanted to explore what would happen if we combine the two of them, having a domain space in the input that is much more generalized by itself, and also extract the latent features and expand on them through the decoder.
You have like target styles that you style transfer in the latent space?
Oh, no, the style is created throughout the training itself. Basically, the style transfer layers are adversarially trained so that the result is as bad as it can be, but keeping the semantic content intact. Problem.
Thank you. More discussions
on the poster. 103.
Thank you very much.
Thank you very much.
Thank you. Okay, next presentation. It's prototype-based interpretable model for glaucoma detection from Mohana Singh from TCS Research. TCS Research, India.
In this work, we propose a prototype-based interpretable design to make any existing or new black box models interpretable. Though it is not limited to any particular domain, we exemplify our contributions in the domain of glaucoma detection. The architecture is composed of three main parts. The first is a simple classification module. Second is a frozen class conditional decoder extracted from a pre-trained conditional VAE and a set of learnable prototype vectors. These prototype vectors are updated in the training process and learn a representation for class-specific prototypes which capture the general characteristics of the pathology or well-known concepts of the disease. The decoder is used to visualize these prototypes. The visualized prototype images are then fed to the feature extractor in the classification module along with the query image, and we get feature vectors for each of the input. Pairs of the query feature vector and the prototype features are fed to a similarity layer to obtain similarity scores, and a final fully connected layer takes a weighted combination of the scores to give the final prediction. The whole model is optimized using a simple cross-entropy loss. An important contribution of this work is the decoupling of the decoder from the classification module, leading to simpler training process and ability to work with higher resolution images. These are some results on the RIM1DL dataset showing our models achieve better performance compared to prototype-based baseline proto-VAE and also achieves comparable performance compared to the black box counterparts. These are some visual comparisons of the prototypes learned for the normal and glaucoma classes. First, we are able to achieve realistic and sharper reconstructions. Second, the concept that seems to be captured is the cupping or enlargement of the optic cups in the glaucoma positive samples, as well as a higher curvature of the vessels is noticed, which are well-known concepts in glaucoma literature. For any further details, please visit us at the poster exhibition. Thank you.
Is Mohana here?
Yeah. Yes.
If there is some question, Mohana is here.
Actually, can you give us an indication of the future work and how you intend to extend this?
Yeah, so currently this is giving a more of a global explanation. The concepts that are getting learned, it's a global representation. We would like to extend it to more of a part prototype based so that we can focus on more fine-grained classification. That would be the next step.
Yeah. Okay. Thank you very much. Any other questions?
Okay, in the poster session.
Yes, on the poster session.
Thank you. Next presentation, the one before the last, using counterfactual information for breast classification diagnosis from Jacudo Nascimento from IST Lisboa. Is Jacinto here?
Bear with me for a moment. Seems like the video doesn't have any content.
There is some problem with that presentation. Can we go to the next one and we'll get back after that?
Yes.
79. Key patches are all you need. Can you find?
Hello, my name is Diogo.
Okay, multiple instance learning framework for robust medical diagnosis. It is Iago Araújo from IST also.
Hello, my name is Diogo Araújo, and I'm going to present the paper, Key Patches Are All You Need, a multiple instance learning framework for robust medical diagnosis. This work was developed by myself, Rita Verdelho, Alceu Bissot, Jacinto Nascimento, Carlos Santiago, and Catarina Barata at ISR Larcis. This paper was a result of the work done at the MIA Breast project founded by FCT. Deep learning models have transformed medical image analysis due to their exceptional performance. However, they are prone to spurious correlations, and often exploit dataset biases to improve results for in-domain data. This compromises their ability to generalize and to be fair. As illustrated in the image, we can see that the vision transformer model focuses on the sticker instead of focusing on the skin lesion, showing its reliances on the confounding element in the image. In this paper, we propose to limit the amount of information these models use to reach the final classification by using multiple instance learning. In our framework, the first step consists in implementing a patch encoder, which can be CNN-based or vision transformer-based. The patch encoder extracts a feature map, where each enters of this feature map corresponds to a patch. By the Mill formulation, each patch is considered an instance, making the whole image a bag. In our classifier, we have two options: the instance level approach, where each patch is classified independently, and then we use a pooling operator to obtain the bag label, or an embedding level approach, where we apply the pooling operator directly on the feature map, and then apply a classifier on the vectorized image representation. This method allows us to limit the amount of information we provide to the classifier, which induces to a more patch-specific image analysis, which in result is more robust to training set biases. Thank you.
Okay. Is Diogo here?
Over there.
Okay. So is there some question for Diogo? Yeah. So you think really key patches is all we need? Yeah. Is a statement some provocative? It's provocative. Yeah. So you think it is one way, one direction we should really go for?
Basically, we should.
Sorry.
I can go there if you want.
Yes, please. Okay. Let's say what first. I think it's a statement. Yes.
So can you hear me?
Yeah.
Okay. So basically, yeah, it was a provocative statement, but what we wanted to prove is like more segmented image analysis, more specific. So a more local image analysis would be something that would improve the models and the explainability and fairness and so on, and the robustness against the bias in the training in the training data. And yeah, in our future work, we basically want to prove that these local regions that multiple instance learning model identifies corresponds to the key concepts and the dermoscopic concepts that the dermatologists identify during the diagnosis. And yeah, basically that's it. If you have any questions, my poster is 106, I believe, or 109. I think, yeah.
It is across many applications.
Yeah. So we have so basically we tested our method in classification of dermoscopic images. So melanoma versus nevus, and also multi-class classification. Then also we tested in mammography image classification with multi-class as well, and binary as well, identifying if there was a mass or if there wasn't a mass, and findings versus non. It was what I wanted to say. And yeah, if you have any questions, I don't know, you can read in the poster. Thank you very much.
No, I think we concluded the session until the break. So I think we are a quarter late, but I think we will manage it. So maybe we can have a short break if somebody wants to go for. I think it's 10:20. So maybe we can do it until 10:30. Get back on 10:30, correct? So have a short break, and if the presenters of the next section, the next session, the oral ones, please send us. Come here. Thank you very much.
I'm going to present more about challenge. I'm Sam Kaya. Yes. Okay. So I have one poster presentation and also 2 minutes. I just wonder whether we have to also, or we had to send. I'm here. I'm working. Did we need to present? So for the about we sent you slides. Okay, but we didn't send you video. We didn't send you.
Okay, the slides are mentioned. If you are the same, if you are the same, yes, sure, it's fine.
Okay. Regarding the poster, so I have one like 7 minute presentation, like 7 minutes plus 3 minutes. I think it's total. Yes, plus 2 minutes. 7 plus 2 minutes, and then the other one is poster plus 2 minutes, like 2 minutes version. Okay. In the plan, I understand there will be at the end poster presentation.
Exactly.
About
I have like 20 or 30 minutes.
yes, exactly.
And then there's also the poster session that we can go there.
Yes. So when and where? So when and where?
I sent an email to everyone, but then it's from this building.
Did you send today? When?
I sent after we finish the show.
Okay. Okay. So that was the question. When and where? And do I need to stand there? A particular session because I want to also follow other presentations.
The poster session in the agenda, it is from 5:30 until 5:50, something like this.
So only half an hour. So I thought we are going to only present this 2 minutes.
Okay, sure. You can be in the poster there to present from 5 to 6 o'clock. That is the only 1 hour slot that's allocated.
And then, but
inside this, we will also have the 20 minutes for the oral presentation.
Okay. Yes. Okay. So I will post the poster like I will.
Yes, you can come here. I mean, you can
so it will be in the afternoon. So we will do regular presentations, and then around 5 we need to
then you can go and sit down. You can be there, and when it's your order, you can come back on the theater.
Okay.
Do the order.
That's fine. Okay. In another building, next building. So you will send an email about it. Okay.
Yes. The orals are in the different buildings and the poster. The poster is in it's a different building. The orals are here. Which room exactly? I don't remember. There exists on the.
Okay. So all the whole
check that we have to receive. You sent it around now, right? Yes. Okay, I've got it. Yes, I just downloaded it.
Okay. So how we're going to do it?
Okay. The bad point, this is one of the first instructions.
Yeah.
Yes, okay. I'll have a look and I'll let you know.
So the whole presentation and
okay, so in the same act, it's also the poster.
It's going to be more video presentations because I just trying to make sure it is.
Have I responded to you?
Yes.
Okay, if I have responded, I have it.
It's 44, I guess.
44, right?
I mean, it has an ID 44, so if you can get 22, 44, it might be mine. It's in the second row.
You can see it because I cannot.
On the right, 22, 44.
Ah, this one. Okay, yes.
I don't know it's mine or not because my one is.
It's this one. Yeah, by Glasston, right? Yes. Okay. No problem. Yes.
So what would be our next thing? I mean, should I only come back here after hanging the poster on the area?
I thought I would say yes. If you want to go just to set up the poster, stay a bit, and when's your time? Now I don't know what time exactly. You can check on the agenda what time you have allocated. Maybe we will be running a bit late, but at that time you can come back here.
Right.
It's a little gymnastic.
Yeah, I understand.
Different building.
Yeah, we didn't have like realistic time because it depends on how things are going.
Yes.
But where I need to hang.
This is it's not the actual building, it's like if you go the other here.
It's in North.
It's not on the generally civil theater is in 2 buildings. The one is Summit, so the other is Summit. It's like 100 meters.
Yeah, I know. So I need to hang it on ours, not in.
Yes, and that's I think in E4. Then there's only one room that has all the posters. You have the poster ID. You just Yes. 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 Generally, from now until 1 o'clock, you can be there and present your poster. But just if you can come here when it's your allocated time for the oral presentation. Yes.
Yes, we have two papers, challenge papers accepted, one or
Okay. Yes. I know the name now. Yes.
oh, really? You have tried?
Generally, because we have been for the competition and also for the works we have been discussing with a lot of people. I know the names and I don't know. Yeah.
Pre-record a video.
Okay, you remember?
65?
65, it's over here, right? Yes, I think I
Hello,
have it.
everyone.
Yeah.
Thanks for watching. To present on slide now.
You want to present as a slide, right?
Yeah.
Rather than the video.
Yeah.
Okay, there's no problem with it. If you can just give me. Okay, let me just download it here. Okay. One moment, because it's disconnected when I move it. So I think that's mine. No, that's mine. No, that's mine. This hasn't connected. Okay, maybe let me try.
Oh, mine is also no name.
Yeah, but I know this is my stick. Okay, give me a second. So I will just remove this. And then I think maybe it will see yours in the laptop or not.
That's cool. Maybe we can use the other
Another
tab.
side?
Yeah.
No, this one doesn't work. No, you need to have something to put in. This is no. This one should work. If not, then the best one maybe you can send it via email, but give it 10 seconds to see if it will sync. Do you have your laptop with you? Okay. Do you have a laptop with you?
Yes.
Can you send this via email?
I can
Check it. Okay, sure, everyone. Yes. Hello. Okay, which is you have sent me the.
No, I haven't sent you. I've just come to ask where should I send my.
Okay. Maybe the best one is sent it in my email. So d.olias@q. Yeah, sure. Yeah. Yeah, so if you can send it now, that would be good so that I can have it. Okay.
Yeah, I will be the second.
Perfect. Thanks. One moment. Did you?
How can I
So
send it?
if you can send it in my email.
Oh, in your email. Okay.
Did you send? Okay, give me one moment to check. Hasn't arrived yet, but let's wait. Maybe, Outlook needs a few minutes. Okay. So, για τα πόστερ. Ναι, ποιος είναι? Πώς είναι το μου έστειλε ένα όλα καλά, θα τα πούμε μετά κάτσε λίγο τώρα γιατί... From now until 1 o'clock, you have to post
whatever, how you like. Okay, thank you. Okay, thank you. Hey, hello. Yeah, nice seeing you. Nice to see you. No, I'm just sending the.
Okay, you have
Yeah,
sent the.
that's it. Yes, we have
Okay,
spoken.
okay,
Yes.
okay. Everything okay? Thank you for your assistance. For the
Did you send?
With the review.
Okay,
Okay.
just bear with me for 2 minutes to see.
In most cases, we followed. In most cases, we followed your suggestion.
I haven't received it yet, but maybe, especially if it's like a big file, Outlook, we need some time to send. So, okay, let's just bear with me.
Πώς θα βρω το νούμερο τώρα. Σε θυμάστε που σε σε ποιο που το βάζω.
你现在要去听。
Ναι, ναι, ναι.
Εγώ θα όπου βρείτε άδεια. Τώρα, ναι. I still haven't received both your emails, but I don't think it's your problem. I think it's Outlook.
Yeah, because the internet speed here is really slow.
Yes, because there are a lot of attendees, you know.
Exactly. So you are so bad. Can we do like that?
To try with Bluetooth, you mean to?
Oh, she called AirDrop.
Sure, give me one moment because I haven't done it through the laptop. I assume you book Air 5. Oh, I got it. You know, I got, no, I mean, I got your email. So I think yours will be arriving shortly as well. Okay, so forget AirDrop. I think we can do it from here. In all cases, thanks.
We'll call you in a bit.
We have also the previous one
the
that
lady.
didn't work. Yes, okay, I need to check it.
Do you need something?
No, they have emailed me the presentation. They want to do it.
Which presentation?
Do you remember what's your ID?
65.
65.
Ah, yes, 65 is later. Yes, yes, yes.
Yes,
Okay.
COVID.
Okay.
Yes.
But you had it.
Yeah, but they prefer to do it live
Okay,
rather than
okay, no problem.
pre-recorded.
If they want, no problem.
Yes.
Yes, okay. Okay, excellent. You will also do the live, the other one, the 64.
64.
Yeah, we want to do it together. Is it okay?
Okay, 65 it arrived.
You have this for that you have sent to us? No.
Which one?
No. You said 65 or not? What's the time?
We're 65.
65, yeah.
You are also 64, yes.
Yeah.
So you make both presentations.
Yes, we want to make it together at 65, and then it'll be okay. It's it's only 1 or 2 slices.
So you would prefer after that to follow this so that you can do it together. Something of that sort, you mean? The one after the other. Okay, I will do it.
This is your one, right?
Okay, I'll do it.
65, right?
65 and 64. 64.
65. Okay, give me just one moment. Okay, so it is number 15 and this is 64 and 65. Okay, so I remove here the 65, the video, and I play yours. Okay, great.
Okay,
all good, right?
Sit down.
Yeah.
Thank you.
And then περίμενε και προηγούμενο. Αυτός ποιος ήταν?
Αυτός είναι το 41.
41.
Είναι πριν το δικό μας.
Πού είμαστε εμείς, μας βλέπεις?
8.
Δεν υπάρχει. Να, το 34-41 δεν υπήρχε.
Τι?
41 το μου
33 και 40 δεν υπήρχε, όχι βέβαια.
Ναι, οκ.
Ναι.
Άρα πάμε 10, 41. PPT.
Και σου έστειλε και ο άλλος ο David, ο Ακλάντα.
Όχι, ναι, περίμενε ένα λεπτό, γιατί έχω και την άλλη πρέπει να δω πάλι το βιντεάκι.
Καλά, το δούμε.
Περίμενε αυτόν τον video.
Βάλε και το για να αρχίσει αυτός.
Περίμενε.
Please get back. To start again, we had this small delay. We're trying and everything.
Okay.
So the first talk will be on enhancing Ki-67 cell segmentation with dual UNet models, a step toward uncertainty-informed active learning. It is from the, it will be presented by David Roger from Image Processing Group in UPC. Okay.
Thank you very much. Works fine.
Oh, yeah, it's okay. Perfect. So thank you very much for letting me present this work here in this workshop. My name is David Roger, and I'm a PhD student from the Image Processing Group of the Universitat Politècnica Catalunya. And today I'm going to present you this work entitled Enhancing Ki-67 Cell Segmentation with Dual UNet Models, Step Towards Uncertainty-Informed Active Learning. Okay, so it's going to be a very brief talk, so don't miss the full paper for all the details. I'm going to put also the QR at the end of my presentation. So I'm going to start with a little bit of the medical background of this approach. We're going to deal with breast cancer histopathological images. So breast cancer is the most common cancer in women worldwide. But if it is a disease that if it's detected in an early stage, the survival rate can be up to 98%. So there's a need for a fast and accurate diagnosis procedure. And this procedure starts with biopsy. Excuse me, it's not working.
Maybe, okay. In those cases, maybe if you touch this, sometimes get disconnected. Okay.
Okay, so they extract a piece of tissue from the breast and they slice this tissue in very thin slides and they stain each one of these tissue slides in some specific stains that brings information to the pathologist to diagnose correctly the disease. And one of the most common stains is the Ki-67 stain. Okay, in this, I'm not going to enter all the medical details, but what we have to know is that regarding this stain, each of the breast can be characterized in two main classes. One is the positive class, which is the stain in brown stain, and one is the negative class, which is a stain in blue stain. But there are also going to be other types of cells that we are going to name them as non-epithelial cells. Okay, and basically the score that they compute based on this stain is called the Ki-67 score, which is the percentage of positive cells over the total of epithelial cells. And they use this score just to decide which kind of treatment do they have to apply to the patient. And commonly this score is computed manually, just counting the cells of the image manually, one by one. So we wanted to automate this procedure, developing a cell segmentation and classification algorithm. Okay, so the first problem that we had to face is again not working very well, but I think I'm going to manage it. Yeah, okay, well, I can skip directly to this slide. Sorry. Okay, so that's life problems, I think, but yeah, or I can present like this if you want. No worries. Let me. Okay, so the first problem that you have to face is that when we are dealing with histopathological images, they are huge images, so we cannot process them at once. So we have to work with crop tiles of these images. So all of our models are going to be applied to these cropped images, size 124 pixels times 124. So our main goal is develop a model that is able to segment each one of the cells and classifies them within these three classes that I have just mentioned. Here in these images, we can see an example of the expected output. In green, we can see the positive cells, the epithelial positive cells, which are stained in blue. And in red, we can see the in red, we can see the positive cells stained in brown, and in green we can see the negative cells stained in blue, and also in yellow we can see the ones that are non-epithelial. So these are the three classes of our segmentation problem. So our main contributions in this work are motivated by three main challenges that we have to face. The first challenge was the lack of annotated data set. Another second challenge was the cell overlapping problem when dealing with cell segmentation. And also we wanted to compute a metric that brings up some results reliability of our segmentations. So the first challenge we overcome is developing ground truth generation method using morphological applications like the MAX31. We also present the dual unit architecture to overcome this cell overlapping problem during the segmentations, and we applied the Monte Carlo dropout algorithm to estimate the epistemic uncertainty of our model. Okay, I'm not going to talk about this part of the work because due to time limitations, but we can check it in the full paper if you are interested. And regarding this dual unit architecture, okay, the whole scheme of our proposed method is the one that you can see here in the screen. First of all, we are going to have a unit that is responsible of the cell segmentation, okay, and we are going to have a second unit which is responsible of detecting the centers. These both units work independently, okay, and the idea behind this second unit is that instead of just trying to find the centers, from the ground truth, we try to build a Gaussian density function based on this ground truth, as we can see here. And the main task of this unit is to regress this density function, and using the predicted density function of the prediction of this unit, we just apply a local maxima estimation, and these local maximas are the ones that are going to be considered at the detected centers of the cells. So using these both output, we can merge them, and we can just have a watershed algorithm using both of them. Yeah, and this allows us to break these huge components that can be found due to this cell overlapping problem, and we can overcome the challenge using these both units. Okay, so regarding the third main contribution of this work is this uncertainty estimation. So we wanted to see how our model was, if we were able to build a robust model or not. Okay, so we estimate the epistemic uncertainty of our model using the Monte Carlo dropout. We just compute 30 different inference steps with dropout in these different steps, and we computed the variance of the predicted probabilities for each one of the pixels and for each one of the classes. And here we can see a heat map that represents the mean of these variances of the classes. Okay, because we wanted to be able to see in which regions our model was not sure about its prediction. But actually what we end up having was something like this. I don't know if you can appreciate it correctly, but the high variances were actually at the contours of the cells instead of in the center. So we had to apply some morphological operations to get rid of these non-interesting high variance contours, because we wanted to focus on the cells that actually our model was not confident at all about their predictions. Okay, so these were our main contributions. And regarding the results, okay, we performed the four-fold cross-validation to evaluate our cell segmentation and classification method. We compared it with the HoverNet model, and we beat the HoverNet model in the both metrics that we selected to evaluate our model. The first metric that we selected was the segmentation at cell level, the F1 score at cell level, but we also wanted to compute the mean absolute error, okay, of the Ki67 score that is computed, again, computing the percentage of positive epithelial cells over all the epithelial cells of the score. So using this approach, we beat the HoverNet in all the folds. But I want to talk a little bit in more detail about the uncertainty results, because we had two different types of cells that presented a high uncertainty, a high variance in their predictions. The first type of cells were the cells that actually were misclassified in the model, and we can see that most of them are misclassified between non-epithelial cells and negative epithelial cells, which are pretty similar. This means that in these cases, our model is not confident of their class. So this means that maybe we have to revisit our ground truth and re-annotate them in order to build this more robust model. And the second, sorry, yeah, I can show it here. Well, you are going to see it right now, but the second type of high uncertainty cells were the ones that were low stained. They were actually corrected well, but due to its low stain, our model were positive or negatives. And maybe also these cells has to be revisited. The function of the cells has to also be revisited for express pathologists in order to build a robust annotated data set that can allow us to build a more robust model. And just to finish with some conclusions. So with this approach, we are able to build a more accurate and faster cell segmentation and classification model for the Ki-67 stain. And we are able also to estimate this epistemic uncertainty of our model, which allows us to just pave the way for an active learning loop, okay? Because we can generate the ground truth with our approach using the max tree algorithm, can correct this ground truth, and then we can train a model, estimate the uncertainty of this model that brings up some cells where our model is not confident of their predictions. And we can use this uncertainty to reconsider some of the labels of our annotated data set. And this allows us to recorrect the ground truth and again, training a new model. And this is the active learning loop that we propose in this work. So first of all, again, this has been a really short presentation. So here you have the full paper with all the details of these main contributions. Sorry for the mistakes on the presentations. Sorry for this live action problem. Okay, I hope they enjoyed the presentation. If you have any questions, I'll be happy to answer. Thank you very much.
Thank you, David. Any questions from the audience? Yes.
So for your relabeling, when you're relabeling some active or anything, who do you get to do that? Do you have to get some histopathology expert, or can you have grad students do it? Who do you have to do it?
That's actually a great question because you have to pay a lot of money to the people to do this job. Okay, but ideally it should be an expert pathologist because the idea is that we show the pathologist these uncertainty maps and we tell them, hey, the model is not sure about this labeling, so can you reconsider it? Maybe the ground truth is not correct or not, but yeah, actually it should be an expert pathologist in this loop. You're welcome.
Are there any questions from the audience? I don't know the picture.
No.
Great. So you mentioned in your last, I think, slide that this is faster than the...
Yes.
Yes. Did you check like the latency? Did you check the complexity? Did you do any such analysis?
Right now I can tell you that it was 10 times much faster than the HoverNet. Yeah, and I think that about the complexity stuff, I don't have the numbers in my mind, but I think that it was lighter and it was faster than the HoverNet. Yeah. Yeah.
Okay, thank you very much.
You're welcome. Thank you.
Thank you very much. Thank you very much. Now we're moving to the second presentation of this session. It is medical image annotation with intent, that means integrated entropy weighting for single image test time adaptation. It will be presented by Fabio Dong from Duke University.
Just bear with me because it got disconnected.
We thank you because he was self-appointed for reviewing some of the papers and to help us with that. Perfect. Yes.
Hi, everyone. My name is Hao Yu, and I'm from the Duke University. Here, I'm going to present our work on the test time adaptation. So to begin with, I want to give an introduction of what test time adaptation is. So it's a type of solution to the domain shift problem where you see the training and testing images are from different distribution. And so this can be quite a common scenario in the medical image analysis, where images can be acquired from different institutions or even just different standard types. So we have seen many works in the previous talk about the domain adaptation, where you'd assume that you have access to both the training and the testing image. But the test time adaptation will assume that instead you don't have access to the training image, and instead you will have access to some networks that is trained on these images. And this can be particularly useful here because we all know the privacy issue of just multiple images. And next, I want to introduce one of the, in my opinion, the fundamental approach in this direction, which is named the TANT. And to do this, I will first do a quick recap of a common concept called the batch normalization. So basically, there are two sets of parameters in the batch normalization layer, which are the statistic parameters that are used to basically normalize the inputs to zero mean standard deviation. And there are the affine parameters, which will basically determine the stats distribution of the output space. So TANT was this first paper that proposed to basically keep all the model parameters except the batch normalization parameters fixed. And they proposed to replace the statistics from the training image to the testing image. And the next, they proposed to optimize the affine parameters so that the entropy of the output will be minimized. So intuitively, they are trying to say if the model is more confident about their predictions, they are more likely to be correct. And more recently, people found that the second step, which is replacing the statistics with the test statistics, has some limitation. So basically, this approach will implicitly assumes that the test images will arrive, you will have access to multiple test images from the same distribution so that basically your estimation of the test stats can be reliable. But in real life scenario, that is often not the case. The images are pretty wild and you cannot have such assumption and your application to the real world can be limited. And people do realize this question recently, and they have some works have proposed to basically first categorize the test image. So instead of assuming every test images are from the same distribution, they will first group the images into different distributions and do the calculation. But here, they still didn't solve the problem of require access to multiple images, which can be another challenge component because it's always hard to collect additional images, especially medical images. So in this paper, we propose to consider this extreme scenario of test time adaptation, which we name as single image TTA. So we would assume that we will only have access to a single test image. So the benefit of this is you don't have to collect any other data other than the data you have. So it's like when you are running diagnosis of your current patient, you don't need to basically collect extra data. And the challenge in this setting is, well, it's really hard to find algorithms that are working. So we're focusing on the segmentation. So our baseline will be the UNet. And we tested 5 different algorithms here. And if you look at the average performance, we basically see there are no significant difference or you can say improvements by other methods. So why is that happening? We assume that maybe it's because by only having access to a single image, your estimation of the test distribution can be pretty unreliable. And this motivates us to propose this new approach. So the first step we did was to basically get more possible estimation of the distribution that are reliable. So recall that we have access to all the training parameters, which will also include the training stats. And the test stats are also available because once you have an image, you can just run the algorithm and obtain them. So next, we propose this step to basically interpolate between the training and the test stats. And we use the symbol lambda to just control the ratio of the queue. And the next, once we do this, we can feed the updated stats to the model, and we will have some different outputs. And here I will present a visual example of what's happening there. So if we switch from lambda to 1 to 0, you can see the outputs will be changed accordingly. And next step, we want to only have a final output in the end, so we can do some average. So instead of doing the simple average, we borrow the idea from Kant that we can somehow rely our prediction on the entropy. So we decided to first define the entropy of a masked prediction as the average of pixel level entropy. And the next, we are just assigning higher weights to lower entropy because we want to assign higher weights to more confident ones. And in this way, we can get an average output as our final prediction. And next results, we tested on 3 datasets from different modalities. And each dataset is multi-domain. And we will train on the segmentation on each of the domain and test it on the remaining. And we also repeat the experiments 10 times here, just for ensure the stability of our algorithm. And on the right are the visual summary of the datasets we use, and the table here basically shows the performance. As you can see, we outperform other methods by some depth there. And lastly, we also did some internal analysis. So the first part we were curious about was how do we integrate between them. So as I said, by doing some weighted average based on entropy, we do get a higher performance, but the improvements are not very significant if you just do simple average. And this will be one of our future study directions. And we also can combine our methods with others, because if you recall from the batch normalization layer, we only adjust the stats parameters. We leave the affine parameters unchanged, but we can also change them by using other methods to optimize their goals. So as you can see here, we tested on 3 smaller sets, and we do see some improvements there. And one last thing I forgot to put in the slides was the step on the choice of lambda. And I will go back to this one. So in this case, we have lambda with step size 0.1. And our experiments show that as long as you use some decent step sets, the performance won't be changing that much. And yeah, that's it. Thank you for listening.
Thank you, Claudio. Any question? Yes, please.
So I guess my question is really about I guess my question is about the choice of like batch normalization. I do say people use like an instance normalization to separate the styles and schematics. So I'm just wondering why batch normalization instead of instance normalization.
Well, our initial motivation was we built our work on the Kant, and the Kant was they choose the batch normalization layer as what they try to optimize for. But yes, what you said is also another motivation, because we were doing the sort of the style transfer works before. So we do know that the stats in the batch normalization layer can be pretty important, especially in our case where you only have a single test image. So you have to somehow rely on the training stats that's available.
Yeah, I do say, I think one reason might be the batch, you can rely on the statistics of the batches, because if we do instance normalization, on the test set, you only have like one, which is like, may not be stable.
Right, exactly.
Okay.
Thank you. I have one short question, actually.
Yes.
I think something that could be interesting, and I don't know if you checked, is if you tried either your approach or as a comparative approach, when you're having synthetic data sets and you have like a synthetic image, is this something that you tried or you want to try or something that you compare to?
Right. That's on our next step. That's literally the next step we plan to do after this. Okay. Thank you.
Okay. Thank you very much. Thank you. We try now to go through a small session describing what happened in the competition that I told you we organized, and I'll give you a short presentation of what happened with what was the problem, and then the three main approaches that were used that got the best results will be described next. So this will drive us to the next invited talk. I think so. This is what we try to do now. Say it.
One moment, I can't find it. No, that's 24. No, different. 41.
One, two, three. Okay, so the competition was composed of two challenges. The first was for COVID-19 detection, and the second was for COVID-19 domain adaptation challenge. And let me describe you what. Something like that. Okay, the COVID-19 detection aimed to build effective models for fast and reliable COVID-19 diagnosis based on 3D chest CT scans. The annotation of these scans referred to the whole 3D signals, that mean not separately to each slice, thus requiring out-of-the-box neural architecture to be handled. In addition, CT scans have different sizes in terms of the number of CT slices, which were these differences were due to different machines used in different hospitals. The data set that we used were extracted from our COVID-19 CT database that we have created last year. And the baseline was part of the deep learning arachnoid model we have also developed there. These were published in a neurocomputing paper last 1 year before, and the data set and baseline were coming out of this publication. On the domain adaptation side, since the CT scans were aggregated from various hospitals and medical centers, then they had different data distributions between hospitals, and our aim was to use domain adaptation so as to diagnose COVID-19 across annotated data sets from some medical sources and non-annotated data sets from other medical sources that we didn't have any annotations. The baseline, I think it was mentioned before in the former presentation. We also used Monte Carlo dropout for multi-forward passes through the network with dropout activated during inference. So to assess the arachnet uncertainty while trained on annotated data, and new data were then annotated based on models' predictions, specifically the ones we had confidence level. So we used this approach. These were also described also in this publication last year as why the data were collected from with different statistics. So the data, you can see the descriptions here on the left part of the slide. We have the number of CT scans. There were about 1661 COVID data scans, 3D scans, and about 6,000 non-COVID. And you can see that then the slices per input were different from 50 up to 70, which are shown in the figure below part of the slide. And there these were annotated with medical experts, both radiologists and pulmonologists. And based on this data set, we got an extract from, as you can see, that we got some training data for the first experiment that was we had annotations, so we had about 700 and from each category, and about 160 from each category for the validation data set. In the second case, where we went for domain adaptation, we really had about 500 non-annotated data, and this was the idea how to use them better in the best way, so to perform very good, the best results we could. Some data samples with COVID that had bilateral ground glass regions in lower lung lobes. You can see them in the right, and non-COVID data scans on the left. The architecture we used was really a CNN RNN network, but with a routing mechanism. We used this routing mechanism driven from other architecture we have developed and going for dense layers and to go for the COVID, non-COVID classification scheme. And the results, it was interesting. We had more than 20 teams that participated in the competition. About half of them, 12 of them submitted results for the detection problem, and about half of them, 10 teams submitted results for domain adaptation. From these results, we compare them to the baseline that we have developed, and 6 and 4 teams respectively overscored the baselines, and they made false submissions. And so you can see here the results, which show that in the case of detection, we got some very high results. As you can see, for example, in the macro F1 score, the first one got about 94.89, but you can see that the other techniques got very close, 94.60, 94.39, 94.24. So it was very interesting that with different techniques based on, you can see some of them just after this talk, we got very good results, similar. You can see that you can see for the COVID and non-COVID categories, which were the best results as well. And so this was the first result we have, the first challenge. The second challenge, the results were lower, especially in the COVID detection, where we had the domain adaptation. You can see again that the results were on the 70s. The results, the macro F1 was 78, 77, 75, the best techniques. Whereas in the non-COVID category, there were very good results. In the COVID category, the results were much lower. And so you can see that these poses us some challenge again. So we got very good results for the models trained and validated with accurate data sets like the one we have generated. The domain adaptation illustrated the current performance of the state-of-the-art approaches and the need for further improvement. And the COVID-19 database is interesting, a large database which can be used for effective training of large data DL models. In fact, it's interesting to mention that there is a very good initiative across Europe, the last running now. We're participating into this, which tries to make a common a common healthcare data set. They call it open health data space across EU countries, and this has an aim to harmonize all relevant databases through EU. And so we are also trying to include this database in this EU initiative. And I think this will be very interesting because we have in the next 2 years or 3 years, we aim at have a big public data space on the healthcare across all European countries based on such a big and trustful data sets. And I think this is something we will continue producing results based on these initiatives. So that's for the moment. The best scoring approaches are presented in the next. The first in each challenge orally, they got some awards. They also got some small funding from our funding organizations, and the rest ones, some of them will be through posters. So thank you very much, and I think we'll go more for the next presentations related to the 2 approaches that won and 1 or 2 that were the runners. Thank you. So the next one is the first approach, and it's separating lungs in CT scans.
You can take this.
Yes. Separating lungs in CT scans to improve COVID-19 detection by Robert Tendon from University of Sydney. He got the first position in the first challenge.
$71, right?
Well,
71.
76.
76.
Just after
76, yes.
Robert, do you hear us?
Yes, I'm here.
Okay.
Hello, everyone. It's great to be with you in this workshop. We want to thank the organisers for running the competition so well over the last few years. Thank you also to all the participants. We wish we could have been with you in person at the conference, but sadly my colleague Simon Much and I needed to. It's great to be with you in this workshop. We really want to forward to hearing from the other presentations remotely and participating in the question and answers.
Yeah.
Our paper is entitled Separating.
Just one moment.
Lungs and CT scans for improved COVID-19 detection, which describes our submission to the 2024 COVID-19 dataset detection competition. In the 2024 competition, there were 2 challenges given to the participants. First was to take over 1,000 CT scans annotated as belonging to patients with or without COVID and to train a classifier. The second challenge was to perform domain adaptation. A smaller data set with CT scans from a different distribution to challenge 1 was provided. This also includes about 500 scans which had not been annotated. The challenge was to use the data set from challenge 1 and the annotated and unannotated data set from challenge 2 to make the best classifications on a distribution like the additional data set. We sought to use 5-fold cross-validation for both challenges. We divided the training data set for challenge 1 into 4 petitions, which together with the official validation set gave us 5 roughly equal petitions for cross-validation. For challenge 2, we combined both the training and validation petitions from the challenge 2 dataset and divided these into roughly 5 equal petitions. We also included the public STOIC dataset, which includes 2,000 CT scans labeled as COVID-19 positive or negative. As we did for our submission last year, we first segment the lungs and crop the 3D volumes to the resulting bounding box. For this year's competition, we also identify and crop each lung separately to be given as inputs to the model individually. The volumes are interpolated to a single size. The crop volumes including both lungs, are interpolated to 256 by 256 by 176. The individual lungs are interpolated to a size of 320 by 160 by 224. We use two neural network architectures, both pre-trained on the Kinetics 400 video classification dataset. The first is a 3D ResNet with adaptations discussed in our submission to last year. The second is a video SWIN transformer of size tiny. These architectures were chosen to have models which could process the 3D volumes as input as a whole and still be able to train on a single GPU. The models were trained for 30 epochs with a batch size of 2 using cross-entropy loss with the Atom Optimizer. Each volume was included in the training and validation datasets twice, with the second one reflected. The brightness and contrast for each scan was randomly adjusted during training. For challenge 2, we trained an ensemble of models using the annotated scans and then made predictions on the unannotated scans. These predictions were then used as pseudo-labels. To not train with too many labels with incorrect pseudo-labels, we only included predictions with a high confidence, meaning that we only included predictions with a probability of 0.7 or greater. These scans with their pseudo-labels were then included in the training dataset for fine-tuning the models for an additional 10 epochs. We trained both architectures for challenge 1 with the two types of inputs, both the lungs together and each lung separately, marked as LR on the plots. The best performing model was the ResNet on both lungs together, which achieved a mean F1 score of 92.5% across the 5 cross-validation partitions. The ResNet LR and the SWIN LR models had a lower mean F1 score than the same architecture with both lungs at the same time, but they also had a lower variance across the 5 cross-validation partitions. Averaging the ResNet and SWIN transform results gave the highest F1 score overall at 93.5%, although including the ResNet LR model produced a slightly lower F1 score at 93.4%, but with a small variance. A ResNet, SWIN transformer, and ResNet LR model were trained to predict the pseudo-labels. The best single model was the SWIN transformer with a mean F1 score of 90.73%. An ensemble of the ResNet and SWIN transformer models achieved an F1 score of 91.2%. If we filter the validation results for only high confidence scans with the probability of being with or without COVID above 0.7, then the F1 score increases to 95.8%. Using this ensemble, predictions were made on the 494 unannotated scans for challenge 2. Of these, 414 predictions were above the threshold of 0.7, and these were assigned as pseudo-labels. This improved the F1 score for the SWIN transformer to 91.22%, with the results for their ResNet decreased by a small amount. The ResNet LR model improved from 88.6% to 89.85%. An ensemble of both the SWIN transformer models with or without those pseudo-labels, together with the ResNet LR model trained with pseudo-labels, achieved the highest F1 score of 92.15%. Each challenge was allowed 5 submissions to the competition. For both challenges, we chose the 5 models which performed best during cross-validation. All submissions averaged results across the models for the 5 cross-validation petitions. 12 teams submitted results to challenge 1 for the competition. Of these, 6 teams achieved the macro F1 score above the baseline. Ours was the winning submission with the highest results in the next 3 teams, all being within 0.65%. 10 teams submitted results to challenge 2, and 4 of these achieved the macro F1 higher than the baseline. Our best result was 0.34% below the winning submission, giving us the place of runner-up. In conclusion, the approach used in this paper achieved a high cross-validation F1 score for both challenges. The best result for challenge 1 was an ensemble of the ResNet and Swin transformer models with an average F1 score of 93.5%. This ensemble achieved the winning result for all teams in challenge 1 of the competition with a macro F1 score on the test set of 94.89%. The best single model for challenge 2 was the Swin transformer at an F1 score of 90.73%. This improved to 91.22 when pseudo labels with high confidence were added to the training set. An ensemble achieved even better results with an F1 score of 92.15%. This ensemble was the highest scoring submission on the test set, was our highest scoring submission on the test set of challenge 2, achieving a runner-up place in the competition with a macro F1 score of 77.21%. As deep learning methods continue to develop for analysis of medical imaging, especially when adapting to new domains, we expect improved outcomes for diagnosis and patient care. Thank you very much, and we look forward to joining you for the question and answer time.
Let me just mention at this point that generally this workshop is a series of workshops that we have been doing like the past 3 years, last year in IEEE ICASP, the year before in ECCV, and the year before in ICCV. And in all those workshops, we have always been conducting those COVID-19 detection challenges, although each year we have been changing the challenges. And there is a group of teams that participate in this challenge and also Robert of this work also was included, that in each year, all those teams have been participating on this. And we would like to thank all of them for their support this time. So coming back to this, which was the winning approach in the first, in the one challenge, are there any questions either virtually or in the audience here about this work?
I think we thanks because this award, they got also an award. Thank you very much, Robert, for your congratulations.
Thank you very much, and thanks very much for running the competition.
Okay. I think we should go now to the next. It's 64 and 65. 64. So the next it was the winners of the second challenge. It's domain adaptation using pseudo labels for COVID-19 detection, and also they got the second fourth position in the first challenge, advancing COVID-19 detection in 3D scan. And this will be presented by Perun Tian from Fudan University, correct?
Yes, yeah.
Excellent.
Hello. Hello. Thanks for the introduction. I'm Jilan from Fudan University, and today I'd like to introduce our work. So domain adaptation using pseudo labels for COVID-19 detection. And our team name is FDVTS, which is the winner of the second domain adaptation track. So generally, I want to first give a recap of the CMC family, which is the winner solution for previous competitions that held in ECCV and ICCV previously. So it was about CMC version 1, V2, and infection-aware CMC, and also the solution to this year's COVID-19 detection, which we called CMC Lite. And later, I will introduce the solution to the domain adaptation track. Okay. So let's start with CMC V1. So the task is about classification of COVID and non-COVID of the CT scans. So it's about training a classification network on these volumes, CT volumes. So there are two key deliveries I want to show you. Is about first one is data preprocessing, which matters much. So it's about how you process the CT images into a compact volume to feed into the neural network. So it is the most critical part, I think, that gives the best result. And the second one is adaptive loss with design, which is a combination of classification loss, which is a normal cross-entropy loss, and also mix-up loss, which is a sort of a data augmentation, and also the contrastive loss, which is a supervised one, because we try to push the samples with the same disease closer, and so this is optimized like this. Adaptive loss just combine the three together with adaptive weights. Okay, so this solution won the first and the ICCV 2021 vitality. Okay. So let's move to the CMC version 2. It did some modifications on the version 1. So I highlighted the three key components, how we modified our architecture and the training paradigms. So the most important one, I think, is the backbone. So we changed the image backbone to the video one as presented by the previous talk. It's about transformer and CNN. They are the hybrid. So we also, the network is pre-trained on the Connectis 400. It's a video data set that for action recognition. And so the temporal information encoded in the network is perhaps similarly to volume here. So that's why it works, okay? So also there are hybrid mix-up and cut mix augmentation and the small resolution training, because it saves a lot of GPU memory for video backbones. And we use a small resolution training and large resolution for testing. Okay. So this solution also won the first prize in the ECCV 2022. And also there is another version called infection-aware CMC. So this is slightly different from the previous one, as it is designed to tackle the severity grading task, which is multi-class classification. So the key here is we design a infection-guided CMC training. So the key is we try to extract first we extract the long region from the CT volumes, then we train a unit like a segmentation network to extract infections from the long regions. So the network later can focus on the infection part. So in during the classification training, we just contact the original CT volumes and the infection masks together to train our classification network. Okay, then goes to the CMC Lite. So here we want to investigate whether, based on the previous experience, can we do a lightweight adaptation to our model? Because sometimes the video backbone or the heavy input slices can cause much to the GPU memory. So here we investigate three types of fine-tuning. The classic one is we fine-tune the entire network. So this is the most costly one, as the backbone and the classifier needs to be fine-tuned end-to-end on the training data. So for another option, you can just freeze the backbone and train the classifier on this data. And for the third one, we try the prompt tuning one. So we add some learnable patterns to the inputs, channel-wise or spatial-wise. There are also options to as you see. And this efficient visual prompt tuning strategy under limited resource computation resources also achieve very good results. Okay, so let's dig into the second part about domain adaptation. So domain adaptation aims to adapt the model to new data distribution, especially when the validation set or perhaps the test set has a very large domain gap with the training set. Perhaps they are collected from different hospitals or with very different image qualities, perhaps. So here, let's see the domain A and domain B. We will refer domain A as the source one and domain B as the target one, because in most cases, domain B is perhaps collected from the different hospitals. So we try to find a decision boundary or classifier that can also classify both those type of images. Okay. So we also perform a two-stage training here. The stage one is mainly about domain invariant training. So it means we want to learn some general patterns that is irrelevant to the domain. So for example, COVID cases, if they're from different hospital, they are supposed to be always COVID. So here we optimize standard loss like CMC and also a novel introduced loss, which I'll describe later. Okay. So the stage two training, we can leverage the model trained in the first stage to label some data in the new domain, because most data in the domain B is not labeled at all. So we can use this very strong classifier to do some pseudo labeling here. Okay, and then we can use this label data and pseudo label data together to train a strong classifier in domain B. Cool. Okay, so the novel loss I mentioned before is about choral loss. So the idea I have shared with you, it's about you try to align the feature representations of the same disease from two domains. So we can achieve something like a domain invariant learning, right? And after the training, we try to label the unannotated data in domain B, and together we have very little annotated data from domain B and the pseudo label data. See, then we can train a very strong classifier. So this model gets the best results from the second challenge. Okay. Okay, so here there show some TSNE visualization and CAM results. As you can see from the TSNE, the left one. So without domain invariant learning, the data from domain A and B, they're tangled. So after domain invariant training, as you can see, the COVID and non-COVID ones, they're better separated. So here's the recap and overall a series of works we've proposed in the recent years, and the code is already public on GitHub. So yeah, that's the most of today's talk. Thank you.
Thank you very much, Rudian. I mean, really very, your participation was very successful. You also good. You were the first in this, the second challenge, and also second in the other. So I think we have congratulations again, and the work that has been also assigned to you. If there is no question, we can proceed because we are really in the short time. Thank you very much.
Thank you. Thank you.
So I think we are coming before the second invited talk. So the next presentation is called Deep Adaptation, and it's a sampling and test augmentation for COVID-19 detection and the domain adaptation from 3D scans. It is the presenter is Fares Bouyurgi from Université Paris and Paris Créteil.
Good morning, everyone. I am.
In our work, in our.
Yeah, as I mentioned previously, generally all those teams, they have participated in all the events, both workshops and competitions that we have been conducting, and we thank them very much. Yes.
Good morning, everyone. I am Bukurzi Fares, and today I will present our work, which is entitled On Sampling and Test Augmentation for COVID-19 Detection and COVID-19 Domain Adaptation from 3D CT scans. First, let's start with our proposed approach. Our proposed approach consists of three main steps. In the first step, which is the pre-processing step, the input slice is fed into pyramidal decoder attention unit for simultaneously segmenting the infection and lung regions. Then, the input slice, the lung regions, and the infection regions are concatenated to produce 3 channels RGB-like images. In the second phase, the pre-processed CT scans are used to train 3D CNN modules, which are customized hybrid decombnet, pre-trained 3D ResNet 18, and pre-trained 3D ResNet 15. In the testing phase, the pre-processed CT scan is augmented 10 times and fed to each 3D CNN module. The testing augmentation prediction probabilities are averaged to produce each module final prediction probability. Finally, the ensembling of the three CNN architectures is performed. As a result, our approach ranked second for COVID-19 detection challenge, and our approach ranked third for COVID-19 domain adaptation challenge. Thanks for your attention.
I don't know if there is some question because these are presenting the results. Paris, I think you are with us, correct? Do you hear
Yes,
us?
yes,
Yes.
yes, I am here. Yes, thank you a
Yes, I
lot
don't know.
for
Thank you very
organizing the
much for your
challenge.
participation. You would like to add something?
No, this is our approach that ranked second in the first competition and third in the second one.
Yeah. Okay. Thank you very much. Congratulations again for your performance.
Okay,
Yes.
thank you again for organizing such amazing competition.
Thank you also, Paris. So
We can move on to the next one, yes.
Presentation is efficient net with special attention mechanism for COVID-19 detection in pulmonary CT scans.
Hello
Rami Farag from University of Missouri.
everyone, my name is Rami Farag and today I'm presenting EfficientNet SAM, a model we developed for the COVID-19 detection challenge. Our model incorporates an efficient CNN architecture and we integrated a special attention mechanism to it. By doing that, we eliminate the need for pre-processing. We also did not combine multiple networks together like CNN with LSTM to keep it simple and efficient. We finished fifth in this year's competition and we were less than 1.3 away from the first place on the macro F1 score. Although our model was trained on less than half the dataset. Here is our model. It has ECANet that extracts a feature map for a given CT scan. Given that extracted feature map, we apply max pooling and mean pooling to compute the max and mean maps. We combine both max map and mean map with 1-by-1 convolution to get the attention mask. After which we apply that attention mask to the original feature map to get the intended feature map. Then we add the intended feature map and the original map together. In the last step, after getting the final map, we experiment with different voting schemes such as simple average voting, ranked voting, and learner-based voting. And here is our model performed compared to the other models in the competition. Thank you very much.
Thank you very much. I don't know, are you here? No. Oh, yes. Sorry, you would like to add something?
I'm very grateful for the question.
Yes.
Yeah.
Are there any questions for Rami?
Okay. Thank you very much, and we are grateful for your participation and your good congratulations for the performance as well. Okay.
Thank you.
Thank you very much. I think this concluded the session with all the competition and the competition, the good challenges and the results, which gave the ability how very good teams participate and contribute and contest on these data sets. And I think this was very interesting for us as well. And we hope to continue to doing that, to give this ability to the good teams to perform better in such contests. So I stop here.
Generally, we would say stay tuned for the future events. So I think now we can move on, and now it's time for me to present the second keynote speaker. It is Professor Greg Slambach, and just to do a small introduction. So Greg is a professor of computer vision and AI and director of the Digital Environment Research Institute, the DERI, at Queen Mary University of London. And let me also mention that DERI is one of the sponsors of this event and some past events that we have. And we thank very much personally Greg and DERI for this. Greg's primary research interests include computer vision and deep learning with applications to computational photography and medical image computing. Prior to joining QMUL, he was a chief scientist in computer vision for Huawei Technologies Research and Development, where he led a team of research scientists working in computational photography. Earlier industrial appointments include the Medic site, where he led a team of research scientists in detection of precancerous lesions in the colon and lung, imaged with computed tomography, with the company's colon cut product receiving FDA clearance and CE marking. He was also an employee of Siemens, where he performed research in medical image computing and 3D shape modeling. He holds 36 granted patents and has roughly 200 publications, according to the Google Scholar currently. He earned a PhD in electrical engineering from Georgia Institute of Technology in Atlanta, USA, where his thesis focused on reconstruction of 3D shapes from 2D photographs. For 6 years, he was an academic at the City University of London, where he was leading research grants funded by the European Commission, by EPSRC and IUK. He was awarded the University-wide Research Student Supervision Award in 2017 and the Teaching in the Schools Award and the School of Mathematics, Computer Science and Engineering in 2016. And because Greg is also at QMUL, that I'm also there, I know that he also has some other newer awards that he has gone, and congratulations. So Greg, are you there? Can you...
Yes. Thank you so much for the introduction. Great. If you could stop sharing, I can share my screen.
Yes.
Fantastic. Thanks so much. Okay, can you see and hear me okay?
Yes, yes, all good.
Fantastic. Okay, so let's get started. Thank you for the introduction, and it's a great honor and pleasure to be here today and present our work on multimodal AI in healthcare. This talk is going to cover different topics like attention, salience, global, local analysis that were mentioned in the call for papers on the workshop. Due to time limits, this presentation is going to be a bit high level, but I do have references at the end if you'd like more information. I'd like to start by talking about a patient's journey in the healthcare system. For example, a patient presenting a condition may be given an assay of tests to characterize their healthcare state. This may include radiology scans, maybe histology, genomics, proteomics, etc. And there may be relevant information in the patient's electronic healthcare record. From all of this data, we'd like to make predictions. For example, a diagnosis or prognosis. Maybe we'd like to predict the patient's response to treatment or their risk of recurrence. Of course, one can analyze each modality separately in order to make a prediction. And in fact, many AI models operate in the realm of a single modality. However, such an approach may neglect the broader clinical context and does not take advantage of all of the data, particularly when it's necessary to leverage multiple modalities in non-obvious ways to make a prediction. Maybe for a patient, we need to leverage their medical record, their radiological scan, and their histology in order to make a really good prediction. In our lab, we've become very interested in multimodal data fusion for integrative healthcare. Rather than analyzing each modality separately, can we bring AI to bring these modalities together? This has the potential to leverage the correlation between modalities, but also their complementarity, essentially extracting as much information as possible from the modalities to make a good diagnosis. However, in this context, a new question emerges, of course, which is how to fuse the data. In this talk, I'm going to present a few vignettes or kind of short research stories that give some context for the work that I'm discussing. And this first vignette is about brain tumor grading. So in this problem, we have data from the Cancer Genome Atlas, and this data consists of histopathology image patches as well as genetic data for each patient. So this is actually a pretty tricky problem because if you look at the image patches, some of the images look quite similar. So grade 2 and grade 3 actually can be easily mistaken for one another. But in addition, we have this genetic data, which consists of copy number variations and mutation status. So we want to bring all this data together to get an accurate diagnosis. We've invented some simple but effective ways to perform fusion of such data. After data normalization, the first thing we do for each modality is put it through an encoder. So for our image patch, we can use a computer vision backbone. In our case, we use ConvNext, but it could be really any backbone, and convert that into a latent feature vector, which represents the image patch. I'm going to call that image vector A, and it can be any number of dimensions, but for simplicity, I'm just going to have a 2x1 vector here called A and B. Similarly, with the genetic data, we also put it through an encoder, in this case an MLP, and we have a vector B, in this case with scalar C and D. Next, we perform bilinear fusion using arithmetic operations. And in particular, we're looking at addition, subtraction, multiplication, and division. But in this case, we're using outer arithmetic operations. So I'm sure many of you will be familiar with the outer product, where you can take two vectors and multiply them together to make a matrix. And in fact, that's what you see in this slide here in the green box. So we've done the outer product of those two vectors there. But actually, before we do the outer product, we append a 1 to the feature vector. And what this does is it preserves the unimodal features. So 1AB is my image feature, and 1CD is my genetic data feature. And so this way, I'm able to get both the multimodal and the unimodal features. And in the multimodal features, we've richly intermingled all of the feature elements together. So we do this not just for multiplication, but also we define new operations for addition and subtraction, as well as division. These are really simple operations. And essentially what this does is it takes these two vectors and converts them into 4 matrices where we've intermingled the data. So we call our method MOAB, which stands for multimodal outer arithmetic block. So what you see here on the left are the encoders and then the matrices that are concatenated together. Then we perform a 1x1 convolution across the channels, flatten, and then perform a classification. And so this method, I've described it in the context of brain tumor grading, but actually the method is agnostic to the problem being solved. It's also agnostic to the data. So it's a very general purpose method. And in fact, the code is on GitHub if you'd like to try it. This paper was presented at ISB last year. This slide shows a qualitative result looking at some of the data in 3D using TSNE. So the point to make here is that if you look at the image on the left, you'll see the dark blue and the brown points. They're kind of intermingled in the same space. And it actually means that it's quite hard to differentiate these grade 2 and grade 3 tumors. But after we apply MOAB, we get a nice separation between these two classes. And unsurprisingly, when we put these features into a classifier, we get much better results. So recently, we've extended the ideas from MOAB into a new technique we call FOA, which stands for Flattened Outer Arithmetic Attention. And essentially what we're doing is looking at this product between the query and the key that's standard and part of a scaled dot product in an attention computation. And we're replacing it with our outer arithmetic operations. So here again, we've got addition, subtraction, multiplication, and division. And we're applying this to the flattened representation of the encoded data. This work was published just a few weeks ago at the ISB conference in Athens. So FOA can be used both for cross-attention and self-attention. It's very versatile. In this slide, what we're showing is how to use it in cross-attention for multimodal fusion. So essentially, we have a vector representing the image data that's shown here in purple in this upper branch, and we pass it down to the lower branch, which is encoding the genetic data. And we use it in across attention, again, using our 4 arithmetic operations. And so essentially, this converts the genetic feature vector into 4 enriched feature vectors that you see over here. And similarly, we do the same thing by passing the genetic feature vector into the cross-attention with the image feature vector, and we get an additional 4 feature vectors here. We combine them and then do a classification. This slide shows some quantitative results on 2 multimodal data sets. The first is the same TCGA brain tumor grading data set that I described earlier. And on this data set, we set a new state-of-the-art using FOA. It outperforms MOAB by a small amount. And we have a second data set here. This is a breast tumor data set where we have radiological images of breast. And in addition, we have data captured from the electronic healthcare record, which includes the patient's age and other variables. And based on our FOA technique, we're able to get a nice improvement compared to previous methods. Okay, I'd like to switch gears now and talk about my second vignette, which relates to rheumatoid arthritis. And this is also a multimodal AI problem, the way we solve it. So patients with rheumatoid arthritis are given drugs to treat their condition, but typically it's not clear at the onset which drug is best for the patient. Here in the UK, where I'm based, patients are typically given methotrexate as the first port of call. Unfortunately, 40% of patients fail to respond to methotrexate. So for these patients, they move on to another drug, an anti-TNF drug, but unfortunately, 50% of patients fail to respond to the anti-TNF drug, and so on. And so you can see the patient goes through a kind of a sequence of drugs, and many of these drugs are not working, which means that the patient's being exposed to toxicity for drugs that don't work. And meanwhile, their disability may be increasing and quality of life going down. So what we'd like to do is really just upend this whole pipeline and take a more precision medicine approach. What we'd like to do is get the right drug to the right patient in the first attempt. And to do that, we've been working on pathotype prediction. So our colleagues at the university have shown that if you can identify the patient's pathotype, it's linked to the drug that they should get. So what we have here are histopathology images taken from patients with inflamed joints, and the samples have been taken with ultrasound-guided biopsy. So we have these whole slide images, and they've been stained with a number of biomarkers which trigger on different biological attributes of the tissue. From this multimodal mix of whole slide images, we want to predict the patient's pathotype into fibroid, diffuse myeloid, and lymphomyeloid classes. Now, there have been a number of talks already today talking about the challenges of whole slide images. These images are huge. And so what's typically done is you do patching. So you patch the tissue into much smaller, more manageable images that you can work with. Another challenge with these images is that the label is at the slide level or patient level. So you don't have pixel level annotation. So for this, typically multiple instance learning is used. We've invented a technique, we call it CRAG, which stands for K nearest neighbor region adjacency graph. And maybe I can take you through this technique a bit. So here we have our collection of whole slide images with different stains. And the first thing we do is apply segmentation. Now, all of these images are spatially aligned, so we only need one segmentation to know where the tissue is. Then for each of our images, we perform patching as described earlier. And then the patches are encoded using a convolutional backbone. This converts each patch into a latent feature vector. And so the next thing we do is form a graph. So we're going to use a graph neural network to process these vectors. And we actually have 2 types of graph here. The first graph is a K nearest neighbor graph. And what this is doing is forming edges between patches that have a similar appearance. So here we look for patches that are very similar and then form a link, and you see that here in this adjacency matrix. In addition, we also form a region adjacency graph. And this is based on spatial proximity. So if we have a patch, we know its neighbors, we provide a 1 in this adjacency matrix for the neighbors. So this way we're able to look at the image kind of at a semantic level as well as a local regional level. And we combine these 2 graph representations together to create CRAG. our K nearest neighbor region adjacency graph. So once we have the graph, then what we do is put it through a graph neural network. So we have graph attention. We also have some SAG pooling, and we go through a number of layers to then make a prediction and provide a heat map. This work was published in BMPC last year, and we have a NeurIPS submission this year, which extends the work. In particular, we apply SAG pooling, which sparsifies the graph as we go deeper into the network. Kind of like max pooling, which reduces the spatial resolution by combining nearby values, SAG pooling uses an attention mask to remove vertices that are less important. And of course, when we remove a vertice, we also remove the related edges. This reduces the graph complexity and aggregates the data from local to global as we go deeper into the network. With our graph representation, we can now generate heat maps that provide a visual interpretation of the model attention, highlighting the regions of the image that are considered most important for the downstream task. On this slide, you can see we can do it for each of our stains. So we have a CD3 channel, which is triggering on specific regions in the image. Similarly for CD21. Interestingly, CD138 is triggering more on the whole tissue compared to the other ones. And we showed these results to a immunologist, and they said that this was expected because CD138 picks up on plasma cells that are distributed throughout the tissue sample, whereas the other markers show inflammatory patterns more localized in the presence of disease. We can also visualize attention scores obtained in each layer of our graph neural network. So in the first layer, the heat map picks up on all nodes in really all 4 stain types, resulting in a more homogeneous heat map. But as we progress through the different layers of the graph neural network, it starts to sparsify the graph, and it actually starts dropping some of the stains that are less important. So by the time we get to the 4th layer, we've actually dropped the H&E stain and the CD3 stain. And so here what we're seeing are results that are triggering more on CD138 and CD20. In my last vignette, I'd like to talk about cardiac MR image segmentation. So here what we would like is a precise segmentation of different anatomical regions of the heart, like the left ventricle, myocardium, and right ventricle. We're using the M&M's 2 data set, which in addition to the image also has metadata available in terms of the vendor, like GE or Philips, as well as the scanner type and the field strength. And I think this is quite interesting because when Ron Summers gave his talk, there was a question about how do you deal with different scanners providing different types of appearances of images. And that's exactly what we wanted to address in this work. So the first thing we do in this work is apply a compositional approach. So we have a single image encoder and we have 2 decoders. So we have a multitask formulation here. And the upper branch is what we call a super segmentation decoder, which is really producing a binary segmentation, identifying pixels that are in the heart region. So this is more global. It's just separating the heart from non-heart. Whereas in the lower branch, we're getting a more precise segmentation where we're getting the actual anatomies of interest, like the left ventricle, right ventricle, and myocardium. So this is more local based on the anatomical reference. So in essence, this compositional approach provides a global local method for image segmentation that is anatomically aware. Okay, the other thing we do is leverage the metadata, as I mentioned before. So here we introduce a module, we call it cross-modal feature integration. And I'm not going to go into all the details due to time, but essentially this provides a way to condition the features in the network based on the metadata. For this, we introduce another encoder, which takes the metadata and expands it into a higher dimensionality using an MLP. We then apply cross-attention with the image and the metadata features, and this enriches the image features based on the metadata. This module adapts the features at every layer of the segmentation network, both on the encoder and decoder sides. Our paper shows state-of-the-art performance on this data set thanks to the compositional approach and also adapting the network to the different domains of scanner and field strength. Our qualitative results show that the super segmentation strategy helps reduce erroneous predictions outside of the heart, as you see here. And our CMFI module, which leverages the metadata, gives us a more refined and precise border for each of the segmented regions. So with that, I'm about out of time. So the key takeaway from this talk is that if there's more data available, use it. And this could be based on multimodal data. And I personally believe that multimodal AI is going to become increasingly more important as these more modalities become available for each patient. But of course, we're going to need new methods to leverage all of that data effectively. So there's a great opportunity for research. Of course, techniques like heat maps and salience can help an AI scientist develop the techniques and understand how the method works. But of course, these techniques can also have important use for clinicians who can better understand what the AI is doing. And this is a way that you can engender trust in your methods. Finally, compositional methods can provide more anatomically aware results, and also taking advantage of the metadata can also improve performance. So with that, I'd like to conclude. Just a quick thank you to my academic collaborators, PhD students, and funders who made this research possible. And here are a few references. Thank you.
Thank you very much, Greg, for this great presentation. So just to start, are there any questions in the audience here? Yes, please.
Thank you. Thanks so much. So you mentioned for vignette 3 a particular data set that you used, and I didn't catch the name of it. I didn't see it actually shown in the slides. Can you just say what that was? Thank you.
Yeah, sure. It's called the M&M's 2 data set, kind of like M&M's, like the candy that you might eat. So this was part of a Mackay challenge a few years ago. M&M's, it stands for multi-vendor, multi-vendor. It's multi-vendor. Oh yeah, multi-site data set. So it's designed to kind of stress test algorithms because they've got data that's collected from different vendors, like Philips, GE, Siemens. So it's a really good data set to work with.
Thank you.
Thank you.
Any other questions? Either. Okay, yes, please.
What do you think will be the next trend of multimodal learning in precisely medical image segmentation?
I'm sorry, can you repeat the question? I didn't quite hear it.
What do you think? What do you think it was both the trend that most likely to be in the future in combining multimodal learning and precisely medical image segmentation?
Greg, did you get that?
No, can you rephrase it? I can hear you much better, Dimitris.
So the idea is that what is your future direction in your estimation if we are to combine multimodality and also if we go towards precision medicine and segmentation? Is my understanding correct?
Oh, okay.
Yes.
Yeah, that's a great question. Thank you. I'm very bullish about multimodal data or precision healthcare. In fact, that's kind of a theme that we have in our lab at Mary. Because, as you get more and more data, these more modalities become available, you can start to really understand, on a personalized basis, the disease mechanisms that a patient may be having. So with this personalization, that leads to precision medicine. And that is really the motivation behind this work in rheumatoid arthritis. If we can figure out what type of drug to give the patient at first, it will save years of being on drugs that don't work. So I think this is a really promising direction. And the other twist I would take on that question also gets into digital twins, which isn't something I've talked about in this presentation. But ultimately, for me, the ultimate personalization is a digital twin for a patient. So if we can come up with some sort of model, whether it's through machine learning or through more mechanistic techniques to understand what's happening with the patient's healthcare, and drive that digital twin based on sensor data that's collected from images or other sensors, I think that's a really promising direction. So super interesting question. Thank you.
Is this clear, or do you have any subsequent one? All clear? Yes. Any other questions? Okay, let me just ask one final question from my side. Okay, so generally in your work, especially when at some points that you were having a multimodal data, and especially some of them were more like feature data, you have used MLPs. And because at the end you touched a little bit on the explainability and the feature maps, and that this can be good both for the research perspective like ourselves and also in terms of the clinicians, what would your view be about GANs? GANs are not GANs with K, like Kolmogorov-Arnold networks. It's something that it's a quite new trend, like it's been like the past month or so. I mean, if you have a view, I mean, the idea is that they want to substitute MLPs, and it's not that they have like a higher performance, at least how they are saying, but they are towards that it's more explainable, because MLPs they're not that much explainable. In general, the deep neural networks, ANNs and DNNs are most like black boxes. So
yeah, super interesting question. Yeah, thank you. I am familiar with CANs. My PhD student, Abbas, he introduced them to me not too long ago. Yeah, very new. So yeah, I think there's, we chose to use an MLP here mainly out of convenience. MLPs are quite easy to implement, and we've got this sort of vector of data here coming from the genetic domain. So yeah, I think it certainly would be possible to replace the MLP with something else. And I think a CAN could be an interesting direction. We haven't tried it just yet. I think the key thing here is from like a biological perspective, what you'd like to know are which of these genes are most relevant for the classification. From a kind of like a drug discovery point of view, that is very interesting, because then you can start identifying new drug targets. But you don't want to, in this multimodal context, you have the image as well. And if you can link the genes that are activated in a classification back to the image and identify how the image is being affected by genetic variants, for example, that is very interesting from sort of a biological and a more clinical point of view. So yeah, I don't have a great answer to your question. I think CANs certainly could be an option, but we haven't tried it just yet.
I think the answer works. I mean, you also gave another direction. So yes, okay, perfect. Thank you very much for this. I guess there are no further questions, right?
Yeah.
Okay, Greg, thank you very much again for your very insightful talk.
Thank you.
Super. Thanks so much.
Okay, so we thank Greg. Now I think we get to the final hour of our workshop, and we go to the poster session. Since the posters have been there already, we will present the paper here. If the author is here, we can ask him to say something and or to ask or to respond to a question. The first paper is unsupervised domain adaptation for multi-cell detection in breast cancer with transformers. It is presented by Oscar Pina from Technical University Catalunya. Is Oscar here? Okay, yes, that's why I mean. But in any case, let us.
Yes, let's play the video. Yeah.
So that we can have also this.
Hi everyone. My name is Oscar Pina. I'm a PhD student at Universitat Politècnica de Catalunya in Barcelona, supervised by Dr. Verónica Vilaplana. I'm going to show you our recent work on digital pathology, named Unsupervised Domain Adaptation for Multi-Stain Cell Detection in Breast Cancer with Transformers. So we are working on breast cancer diagnosis, which is based on cell analysis and counting across 4 immunohistochemical stains. The problem here is that the majority of the annotated datasets for cell detection, which is the task we are addressing here, are on another stain, hematoxylin and eosin. So no annotations are generally available for immunohistochemical stains. Our challenge is then, given a model trained for cell detection on hematoxylin, for which we are using cell detection transformers, how can we make this model work in the other stains? As by default it doesn't generalize and we don't have the annotations to train it in a supervised manner. Our solution is based on unsupervised domain adaptation, concretely with adversarial query transformers. The idea is to train the model for cell detection on hematoxylin while aligning the latent space for images coming from different stains via adversarial learning. The results show that in except over 2, that highlights the membranes of the cells rather than their nuclei, the adapted model can effectively detect cell nuclei and outperform other methods. Indeed, the latent representations are invariant to the stain of the input images. To summarize, we can use unsupervised domain adaptation to bridge the gap between annotated and unlabeled datasets in different stains, and adversarial feature alignment shows the best results. Come to our poster spot if you want to know more details about it, and you can also check out the repo or contact me. Thank you so much for listening.
As we mentioned, the authors are now in the poster session, so we can move on to the next one.
Poster is evaluating confidence calibration in endoscopic diagnosis models by Niku Degahani from Eindhoven University Technology.
Hello everyone, I'm happy to share our work on behalf of our team at Eindhoven University of Technology on evaluating confidence calibration in endoscopic diagnosis models. Patient prognosis may be adversely affected if models produce confident predictions for incorrect diagnosis of colorectal polyps. Confidence calibration measurements provide a more complete understanding of the performance of a model by estimating how closely confidence matches the accuracy. Therefore, we aim to investigate widely used model calibration techniques and how they translate into clinical applications. For that, we use 2 datasets. The CRP dataset, which is an in-house dataset, and 1 external polar dataset. The confidence calibration methods, we use temperature scaling, stochastic variational inference, and last layer Laplace approximation. Experimental results are available in this slide. The first table shows the categorization and calibration performance of the models when trained and evaluated on the same dataset, and in the second one when evaluated on samples from a dataset that is distinct from the one used for training. Multiple intra-dataset and inter-dataset experiments, we explored the robustness of the calibration performance of these methods and their applicability to colorectal polyp characterization. The results demonstrate that the SBI method, while providing a superior calibration performance for intra-dataset experiments, falls behind in test time efficiency and inter-dataset generalization. The Laplace approximation and temperature scaling methods provide better calibration through cross-dataset examination, but utilizing the Laplace approximation does not provide a significant improvement to the calibration performance compared to the baseline in an intra-dataset assessment. Thank you for your attention. Please, for more information, contact us or find us at the poster.
Nico, would like to say something? I mean, was this successful, the confidence estimation for that you can see it is generalized, or it can be, do you consider it something that could be generalized in general apart from endoscopic diagnosis and so on?
Yeah, so these methods have been widely used in other applications, but this method we're trying to see which one would be better translatable to our application, which is endoscopic diagnosis model. And yeah, for that, we evaluated based on both datasets are endoscopic model, but they're all multiple papers before that we also used, and that have been implemented these for example, natural images or other things.
Okay, thank you very much. Okay, we can move to number 63. Bridging domains in melanoma diagnosis. It's Carlos Hernandez Perez from UPC. Okay, is Carlos here?
Hello.
Yes? No, he's the host. Okay, but we can hear the presentation.
My name is Carlos Hernandez, and I'm here to present the paper Bridging Domains. My name is Carlos Hernandez, and I'm here to present the paper Bridging Domains in Melanoma Diagnostics. In this paper, we do what is a standard approach in whole slide image processing. We start with the images, and then we obtain a mask from the image, and it is within these masks that we patch it. And then we for each image, we obtain a set of patches. We use those patches and extracted features from them, what we call patches embeddings. And we use 3 different feature structures. The first one, we just took it as it was. We took the weights and we inferred from it, and it was trained on different skin types of the TCGA datasets. The second feature structure that we used, we took the weights that were from the original DynoV2 paper from Meta, and then we fine-tuned it using only skin cancer tissue. And then on the third feature structure, we again used a DynoV2 model that was pre-trained on the meta weights. It was fine-tuned with colorectal cancer weights, and then we further fine-tuned it using skin cancer histopathologies. Then once we obtained the patch embeddings, what we did was encode them to obtain a whole slide image embedding, and we used different techniques, being just computing the mean of all the embeddings or using different attention or transformer mechanisms. And we did this for the BRAF mutation prediction and for the sentinel lymph node prediction. The results are the following. For the BRAF mutation, we see that it's feasible to obtain a classifier that can infer this information from just the whole slide images, and that domain-adapted feature structures perform better than their counterparts. For the sentinel lymph node biopsy, we see that our models did not perform better than a random classifier. We think that this is because we are trying to predict something, which is the positivity of the sentinel lymph node that is not specifically depicted in the image itself, because the image is from a primary tumor, not the sentinel lymph node. Thank you for listening.
Thanks for that. So we move again to the next talk, improving consistency in cardiovascular disease risk assessment, cross-camera adaptation for retinal images. Danli C. from the Hong Kong University. Danli?
Hello everyone, we are from the Hong Kong Polytechnic University, and today we are excited to share our novel cross-camera domain adaptation method designed to enhance cardiovascular disease risk assessment using retinal images captured by different cameras. Our approach addresses the challenges of achieving consistency and adaptability in this critical area. Firstly, as shown on the left, we employ an enhanced ordinal CVD risk classification approach to predict 10-scale CVD risk levels. This method effectively captures the ordinal relationship and invasive information within retinal images and ensures accurate risk prediction. Additionally, based on this classification approach, we have incorporated a plug-and-play risk consistency loss into the image translation model as shown on the right. This ensures alignment in risk assessments across different image domains. From Table 1, we can see the effectiveness of the proposed method in achieving consistent CVD risk assessment across different cameras. Furthermore, Table 2 shows our model's generalization ability through the external evaluations. And the variation examples on the right reveal that post-adaptation images are more similar to target domain images, indicating the successful domain alignment. In summary, our research provides a robust and adaptable solution for CVD risk assessment across different cameras, and it can benefit patients and doctors in their efforts to combat cardiovascular diseases. That's the end for our sharing. Thank you very much.
Thank you. So, next, one class classification-based quality assurance of delineation
colleagues.
radiographs of organs at risk, delineation at radiotherapy. It's Sevin Liu. Sevin, you're here. Sevin Liu from San Juan University. Okay, maybe you can hear me.
Okay. I'm honored to present our research on the quality assurance of organs at risk segmentation in CVPR 2024. In this paper, we address critical challenges related to the accuracy, reliability, and the interpretability of delineations. Our work leverages cutting-edge techniques from computer vision, machine learning, and domain-specific knowledge to ensure that our medical professionals receive high-quality delineations for diagnosis and treatment. Our aim is to detect delineations that are in low quality. To be more specific, our workflow includes 5 steps. In the training process, we acquire the CT images completed by experienced physicians and auto contour software. Then we evaluate the quality of contour with different metrics before we pre-processing this data and extract their features. Finally, we trained a one-class classifier to classify the quality of these contours. Our strength is that we can detect different kinds of errors that occurs in the delineation, no matter it is caused by an inexperienced doctor or automatic software. Here are some good and bad quality contours classified by our method. As you can see, A, E, C, G are good contours, while B, D, F, H are bad contours. Thank you for your attention, and that's all of our presentation.
So, you have a question?
Actually, I have one question. My question is, since the training set had the high quality and the test set had the low quality, did you try to reduce the quality of the training set and also maybe ask the documentation?
The documentation. Did you do any data augmentation?
Or did you try to reduce the quality of your training data set? Yes. Okay. Okay, yeah, that's it. Any other questions?
Okay.
Okay, so
now, next
thank
one.
you.
A deep clustering framework for brain network analysis. MD Abdul Rahman from Georgia State University. I don't know.
Hello, everyone.
Abdul?
We present a deep bi-clustering framework for brain network analysis. Now, what is brain network? Different brain components are functionally connected to perform regular brain activities and cognitive responses. That connectivity generates a fully connected graph, which is popularly known as brain network. This network has diverse submodules or clusters, which is responsible for a specific neurological task. Finding these clusters can explain the underlying system better. So we are motivated to find out those clusters. However, subject heterogeneity and disease subtypes makes 1D clustering significantly less effective with smaller homogeneous subgroups of subjects. So we propose a single framework to learn the brain networks and bi-cluster its constituents simultaneously. Here is the proposed architecture. The architecture is motivated to facilitate the bi-clustering approach using a bottleneck layer, where the size of the bottleneck, that is the number of neurons in the hidden layer, is divided by the number of expected bi-clusters. We jointly optimize to distribution for feature and sample selections by learning to projection operators. Then we use scale divergence between a high confidence assignment to define the projection parameters that we showed in the earlier step. Here's the performance analysis. We compared our results with several state-of-the-art methods for bi-clustering on 2 benchmark datasets. The methods outperforms the comparing methods in biclustering quality and functional clustering index, also known as functional coherence. As you can see from the figure, the biclusters are more modular and spatially constrained within the functional domain, interpreting the neurological relevance. And this spatial constraint, that is the more modularity in specific neural domains, it helps us understand the activity or the correlations of this specific bicluster with the neurological expressions well. Here, these are the results. We have more we can discuss on. Thank you for your patience. Don't hesitate to shoot an email to the corresponding author for further discussion. Thank you very much.
Okay, thank you very much. Next, learning severity representation for medical imaging using contrastive learning. Class preference.
Have you ever booked an appointment in some healthcare institution and wait for a long time until it's your turn to get in treatment? What if we can rank severities in general and in medical image so that the most severe case has high priorities in treatment? We can monitor whether the patient is getting worse over time or if the treatment is working well. We have discussed this with the medical expert in ophthalmology. It turned out that they prefer to compare two images and point out which one is more severe rather than classify each into predefined classes, such as benign, mild, or severe. Based on this idea, we proposed a novel approach to inject severity information into image embedding space in a pairwise manner. Different from traditional representation learning that maximizes the distance between severity classes, our method rearranges the representation vector from less severe to more severe with respect to the distance to normality using preference optimization. The framework is shown in figure D, and the desired feature space is shown in figure B and C. The results show that control achieved up to 6 and 20% relative improvement compared to supervised and self-supervised baseline. Also, TSNE plots show that control pushed the most severe data point into the tail and relatively arranged the feature space from severe to less severe to normal. We use MRE as evaluation metric because it's sensitive to serious incorrect prediction.
Thank you. Thank you very much. Next presentation. Classification of 2D ultrasound breast cancer images with deep learning. Kofi Aprias, University of York.
Breast cancer is the second most prevalent form of cancer amongst women and is the leading cause of most cancer-related deaths in women around the world. Most women survive their disease for 5 years or more if diagnosed at the earliest stage, highlighting the need for a more accurate and efficient method for detecting and diagnosing breast cancer. Women who live in low and middle income countries have restricted access to treatment facilities and in general a lack of screening programs, screening which could be vital in saving lives. The aim of this project was to develop and deploy a simple classifier on a mobile device to detect breast cancer cases that may need medical attention. We aimed to deploy on inexpensive hardware such that it can benefit as many people as possible around the world. We also aimed to test different machine learning models to find the most accurate solution to this problem, with some of our dataset being displayed at the bottom of the screen, with examples of benign ultrasound images and malignant ultrasound images. For our approach, we built and tested many different network structures and compared their suitability for this problem by ranking them by their accuracy scores. We used an existing public dataset consisting of high-quality breast cancer ultrasound images, also known as the BUSI dataset, and complemented them with images obtained through our radiology contacts. We utilize common machine learning techniques to aid with the common problems of having a small dataset, including data augmentation and regularization, to mitigate against any overfitting. For training, a single NVIDIA A40 GPU is used for 50 epochs and no early stopping to ensure fairness across all of our tests. So what do we find? We found that with pre-trained models using the ImageNet dataset, they are more accurate than their de novo counterparts, models that have been trained from scratch. Not only are the models more accurate, but they take less time to train, because they've already been partially trained on image data.
Yes, yes.
Okay, thank you very much. There are a couple of papers which have provided very high lengthy presentations, which I cannot.
Hello, everyone.
But we go to fetal ECG extraction on the time frequency domain using conditional GANs by Miguel, University of Houston.
I'm Will. Today I'm going to present about my paper, fetal ECG extraction on time frequency domain using conditional GAN. This task is to separate the fetal ECG from maternal ECG mixed in abdominal ECG captured by electrodes placed on abdomen of the pregnant mothers. Previous works either use classical signal processing methods or CNN to perform this task. They suffer some limitations. For example, conversion issues like precision. They require large amount of training data and data pre-processing effort as well. In this work, we propose to transform the ECG data into time frequency domain, and we build a framework based on the conditional GAN to perform this task. An overview of our framework is given here, where from the raw 1D signals, we generate the spectrograms of the 1D signals using short-time Fourier transform. Then we have the pair of abdominal ECG and fetal ECG spectrograms. They are then fed to a conditional GAN, where we employ pitch-to-pitch GAN, and we treat the task as a image translation task, and we attempt to generate the fetal ECG spectrograms from the input abdominal ECG spectrograms. We then compare our method with a conventional method, and we compare the generated spectrograms using mean square errors and structural similarity index. We use the dataset named Abdominal and Direct Fetal ECG database. And looking at the box plots here, we achieve a much lower mean square error and a much higher similarity index. And looking at the sample spectrogram generated here, we can see that compared to ground truth, our proposed method generate a much more accurate fetal ECG signal than the conventional method. And this is the end of my presentation. Thank you.
Thank you. Okay, now we are going to hear about the residual-based LMS R3 booster for biomedical imaging from Ying Yu, Cornell University.
So, hello everyone. My name is Jingwu. Today I'm very happy to have this opportunities to present our paper, Residual-Based Language Models are Free Boosters for Biomedical Imaging Tasks. So this paper is based on very naive ideas, but achieve a relatively good result. And before the start of this presentation for this paper, I would like to first thank all of my co-authors for their efforts, for their insightful discussions, and for their time devoted in this project. I would like to start the introduction of this paper with large language models, which is a super hot topic nowadays. So large language model is composed of transformers architectures, which is originally proposed to capture the long-term dependency over sequential data, just like languages, text, and so on and so forth. And after that, researchers in this domain also found that transformer can do relatively good jobs in different kind of areas with different kind of modality data, such as images and videos, audios, and so on and so forth. So transformer also show very promising result in image captions, video understanding, and so on and so forth. And as we scale up the size of transformer or the number of transformers, we increase the size of the large language models, and we can see that the language model is showing better and better performance. And based on the result from text generation and the understandings, we can, as long as we increase the size of language models, we can ensure the performance model is gonna getting better and better. So that's about language models. And I would like to also briefly talk about the biomedical image task, which researchers from the domain of machine learning or artificial intelligence is trying to build models based on those kind of like special data. And they use those kind of models for diagnosis and treatment. So for example, if our machine learning model is able to capture the abnormal patterns for different kind of patient, we are able to make plans or treatments in advance. And that's a good thing, but on the other hand, one of the challenging things is like the biomedical images is relatively different with the natural images. So generally speaking, the patterns in those biomedical images is irregular, and in the same times, the biomedical images is in a more fine-grained form. In other words, several pixels in those images could represent one pattern, which could be ignored in the domain of natural images. So that's why we think about it, why don't we take advantage of language models to push the boundaries of the learning abilities for biomedical imaging task? So how can we actually use or take advantage of large language models to benefit the task of biomedical images? Here is what we got. So generally speaking, this study proposed using language models traditionally used for text or languages as part of a video encoder, which is shown on the right-hand side. And please note that we want to always froze the block from large language models and just plugging that block from language models in the middle of vision transformer. And as you can see from the right-hand side, the green box is gonna represent the language model modules we plugged in. And to be more specific, we want to integrate a frozen transformer block, which is a small part of the transformer into the large language models. And to enable such a kind of design, we also additionally train or introduce adaptation layers before and after the large language modules. And beyond that, we also add residual connections before and after the large language blocks to preserve information, just like the traditional design for ResNet or transformer. And such a setup, even though it looks very straightforward, but surprisingly, it achieves a really good result. So empirically speaking, we prove that the large language modules can act as a plug-and-play boosters for visual tasks in these biomedical imaging domains. And to evaluate the effectiveness of our proposed method, we are trying to do our experiment on extensive kind of data set in medical minutes data set. It's just not just like incorporate 2D data set. It can also we also conduct experiment on 3D data set, and we're trying to evaluate take advantage of the metric of accuracy and AUC accordingly. And here we are able to see the result. So for the figure on the left-hand side, for the red plot is the original baseline modules. It can be ResNet, it can be like VGG models, it can be more modern transformer, which is a vision transformer here. And the purple areas is the base model with the large language model plugged in. So if you focus on the table on the right-hand side, we report the result for the data set under 2D and 3D settings. And no matter what kind of data set we are using, and no matter what kind of backbone we are using, every time we plug in the residual-based large language models, we are always able to see improvement of the performance of the classification result. And beyond that, we also do some visualizations to prove the importance or effectiveness of the residual-based large language models in our experiment. So, for example, if we want to detect one of the patterns from in the biomedical images, and we plug in the and we do some visualizations of the heat map, and every time we plug in the residual based large language models, we can see the heat map is actually put more emphasis on those more important areas. That's why our residual large language models can eventually benefit the classification result. So that's for the presentations. And to briefly summarize these presentations, this study demonstrates that language models or large language models can effectively boost the performance of biomedical image tasks. So for the future directions, we are trying to incorporate the task that is more fine-grained, just like segmentation task or some of the object detection tasks. And we also plan to experiment with this framework on more extensive data set to prove the effectiveness of such a method. And thank you. Please let me know if you have any questions in the following.
Thank you. I think we had a problem. Probably you have seen that your presentation was only the first slide. It will not include the next slides. So as you mentioned, can you, if you'd like to share the next presentation, the next slides with us, we can share it. We can upload it if you like to the workshop site. Okay.
Yeah, I appreciate that. And if you have need for the slides, I can also send privately via the email address in the chat box. Yeah.
Actually, you can publicly share it on the chat so that the other attendees can also download. I think that there exists this option.
Yeah, I'm gonna do that.
That would be the best, yes.
Okay, please do. Thank you very much, King.
Yeah. Thank you very much. Yeah.
Okay. Now we try to move the last presentation because the author has to leave after 1 o'clock, and we get a bit further. So we now proceed with focus on what matters: free-grained activity recognition for trauma research station from Wenjing Zhang from Rutgers University. So can we have the...
Hello everyone, my name is Wenjin Zhang. I'm a PhD student from Rutgers University. Today I will present our paper focusing on what matters: fine-grained medical activity recognition for trauma resuscitation via act tracking. I'm sorry that I cannot present our paper in person because of my inter-schedule conflict with a conference. I'm happy to answer any questions virtually. This work is motivated by the importance of trauma treatment. Nowadays, trauma accounts for 47% of deaths. It's a leading cause of deaths. Among them, 20% deaths are preventable because of human error. For example, rule-based human error and knowledge-based human error. Our main goal is to develop a decision support system which can monitor the treatment and help make decisions to mitigate human error. In this paper, we focus on the medical activity recognition with computer vision method for the monitor treatment. Compared with traditional human activity recognition task, our task introduces 3 kinds of challenges. First, we focus on recognize fine-grained activity, for example, IV placement activity. This challenge here is that IV needle is very small. It occupies less than 5% of the entire camera view, making it difficult to learn this pattern from the whole view. Secondly, the activities are recognized in complex environment, with crowded people, which can sometimes block the cameras, cause the occlusion issue. Lastly, we are limited by the amount of labeling data. Labeling this data is expensive because the domain experts are is busy with the medical treatment. Our target is to overcome this issue and develop a practical recognition model to recognize the treatment. First, for this problem, it is unwise to perform activity recognition by analyzing the noise entire view. Our main idea is using heuristic information to increase the attention on the region of interest. In our application scenario, all the medical activities are performed by doctor and nurse. Then we can focus on the motion of each actor. Now let's take a look at the whole system view. The actor tracker can track the actors, include the bounding box and the actor identification from the frame views, from the frame sequence. Simultaneously, a vision transformer continues to extract the spatial and temporal features from the video stream. With the help of bounding box and the actor identification, the MLP classifier header can focus on the action features of each actor to recognize a medical activity. To extract a fixed feature map from the arbitrary sized region of interest, a region of interest align is applied. And finally, the ensemble vision smooths the prediction score across time to enhance the performance. Why do we need an actor tracker? Activity recognition relies on the same actor's features from the consecutive frames, so we need to not only detect but also track them. The tracking procedure is shown on the right. We maintain a data structure called the tracking set, which saves the bounding box and the corresponding actor's ID. We first use common filters to estimate the update the bounding box at time t according to the tracklet time -1. After actor detector, here we use ULV8, predicting the new detection from frame T. We perform the ID match between the detect bounding box and the bounding box in the track set. According to the detect score, we perform two different matching strategies. Specifically, if the detect score is over a threshold, we consider IOU and the ID features at the semantic metric. Otherwise, we consider the IOU features. Based on the matching result, we should maintain the track set for next stage. Let's discuss IOU distance. It defined as 1 minus 1, the intersection of the union between the detect bounding box and the tracklet bounding box. The IOU distance measure can be effective for the long time tracking, because when the actors is accrued for a long period, the bounding box estimation by the common filter become unreliable. To address this problem, our approach involves real ID features matching. We use a BOT model to extract real ID features. Given the potential unreliable real ID features, we use exponential moving average method to update the average real ID feature. Specifically, the ID features at time t is computed by take the summation of 90% of previous ID features and the 10% of current detect ID features. Here, the beta acts as a momentum term. We use a cosine similarity to measure the similarity between the real ID features. With the real ID features, when the actors go out of the camera view, we can still tracking them. Labeling the large volume of video data is challenging because higher domain export is expensive. We use a video MAE to pre-train our model, our feature extractor in self-supervised training manner. It introduced a video reconstruct task by random mask out the video terms and reconstruct them through the encoder and the decoder. After training, the encoder can better abstract the features from the input videos. Then we use the encoder as our feature extractor. The vision occlusion can lead in the noise prediction for the model. Ensemble feature enhance the model robustness. Here is the idea. The minimal duration for the activities was over 30 seconds, which significantly exceeded our model inference time, where the interval is 1 second. A moving average method can smooth the prediction score over time. Our system was tested and deployed at the Children's National Medical Center. A camera is mounted on the ceiling. Over 2 years, we recorded 230 trauma recitation cases. We focus on 5 medical activities. Among them, IV and temperature measurement are challenging. Our method is only compared with our earliest works in the medical activity recognition. A variant of the general video understanding model are invalid in the ablation study. We measure the performance using the average precision score. Our method outperformed the existing medical activity recognition model, especially in detect small-scale activity like IV placement and temperature measurement. We conduct several ablation studies to gain the insight into the characteristics of our method. Specifically, we vary the active tracker, ensemble fusion, and the video MAE. Different backbone architectures was tested. Here, among them, we tested the VIT large, VIT base, the I3D, and the slow fast architecture. So from this result, we can see the VIT large achieved the highest performance. To make a conclusion, we define a fine-grained medical activity recognition system that achieves excellent performance. We introduce actor tracker to isolate the actor-specific features and enhance model focus. We use ensemble fusion method to increase reliability by integrating the prediction from the consecutive video clips. Thanks.
Okay. Thank you very much, Wenjin. I don't know, is there some question for Mr. Chang?
Yeah, thank you for the chair to host that. Yeah, I'm happy to answer any question here.
Okay. Okay, I think thank you very much. Glad hope you managed to reach the time you needed. Okay. Thank you very much.
Thank you.
Okay.
Thank you.
We have two more papers. The first is on latent prompt assist model for medical vision question answering from Tian Cheng Gu from the University of Sydney.
Hi everyone, my name is Tian Chen. Today, I'm excited to present our recent work. Our team from the University of Sydney and DeepClient has developed a new model called LAPA, which stands for Latent Prompt Assist. This model is designed for the medical visual question answering fields, which is the MedVQA fields. Our goal is to revolutionize how we interact with and extract insights from medical images and related questions, ultimately helping physicians in their critical tasks. For those unfamiliar, MedVQA involves automatically predicting correct answers to questions about medical images. This is a complex task due to the intricate nature of medical images and the necessity for precise answers. Traditional methods heavily rely on pre-training models and fine-tuning with extensive datasets. We saw the potential to use existing models to extract clinical relevant information more efficiently. The LAPA model leverages a latent prompt to filter and extract the clinical information, adding in the final answer prediction. Here is how it works. The latent prompt generation module creates prompts that focus on those relevant to the target answer. These prompts are integrated into the multimodal fusion block, which merges uni and multimodal information to filter and extract clinical details. The latent prompt also interacts with prior knowledge about organ disease relationships from a knowledge graph, enhancing the prediction process. Finally, the latent prompt combines the image language cross-modal information to produce the final answer. Our main contributions are as follows. First, we introduce the latent prompt generation model and use a multimodal fusion block to filter and extract clinical relevant information. Second, we leverage prior knowledge of organ disease relationships using a graph neural network to enhance answer prediction. Our LAPA model demonstrates exceptional performance on the three benchmarks. The LAPA model combines innovative components to tackle the complexities of MedVQA. At its core, the latent prompt generation module creates precise prompts influenced by target answer tokens, focusing on relevant information. These prompts are integrated with features extracted from images and language using SOTA tools like the Swing Transformer and Robota. The multimodal fusion block uses self-attention to distinguish information from medical images and questions, followed by cross-attention to merge these features into a comprehensive understanding. Additionally, a prior knowledge fusing module leveraging a graph neural network analyzes the relationship between organs and diseases from a knowledge graph, adding contextual depth. Our experiments on 3 publicly available MedVQA datasets, VQA-RED, SELECT, and VQA 2019, have yielded remarkable results. LAPA outperforms the SOTA model ARL with improvements of 1.83%, 0.63%, and 1.80% respectively. This demonstrates the superior performance of our model in understanding and answering medical visual questions. To ensure our enhancements are robust, we conducted an application study. This study revealed that each component of LAPA significantly contributes to the model's overall performance. We identified the optimal setting for the latent prompt size and the interaction coefficients, providing further insight into the model's configuration. The hyperparameter theta and beta are crucial for modeling cross-model interaction, affecting the accuracy of predictive responses. This figure uses heat map to show how different theta and beta values impact the fusion of image and language features across 3 benchmark datasets. With the latent prompt coefficient alpha set to 1 and latent prompt size fixed at 32, we vary the theta and beta from 0.01 to 1. The results show that beta and theta are equal to 0.1, yield optimal performance across all datasets. The size of the latent prompt significantly affects the parameter count within the framework. This table analyzes the impact of latent prompt size ranging from 4 to 256 on performance. Initially, increasing the latent prompt size improves performance, but accuracy declines when the size exceeds 32. Optimal accuracy is achieved with a latent prompt size of 32. We emphasize the larger latent prompts may introduce unnecessary noise, negatively affecting the precision of final predictions in the MedVQA. To demonstrate the effectiveness of our LAPA model, we conducted a qualitative analysis on 6 MedVQA instances, 3 from the VQA-RED dataset, which is ABC, and 3 from SELECT datasets D, E, F. In cases A, B, C, D, and F, latent prompts enable the model to accurately address both closed-ended and open-ended questions. However, in case E, latent prompts alone were insufficient to distinguish between 2 similar responses. The integration of the prior knowledge fusion model corrects this issue. These 6 cases collectively demonstrated that our enhancements significantly improve the model's performance in addressing both closed-ended and open-ended VQA questions. Finally, in conclusion, the LAPA model represents a significant leap forward in MedVQA by harnessing the power of latent prompts and multimodal fusion. We have created a tool that can greatly assist the medical professional in their diagnostic processes. We are excited about the potential application of LAPA and look forward to its integration into clinical settings.
Okay,
That's all my presentation. Thank you to my collaborators and to all of you for your attention and listening. Here is the link of our project. If you have interest in, you can go to and check that. Thanks a lot. That's all.
Okay. Thank you. We ran out of time now. It's one presentation more, so we will finish with that. It is interactive medical imaging learning framework from Madrid Rao, Stanford University.
Hi, my name is Adrit, and I will be presenting our work on IMIL, the Interactive Medical Image Learning Framework. Computer vision is being widely leveraged for medical image analysis. Although performance-based metrics such as accuracy are necessary for gauging algorithm performance, they do not truly represent the interpretability nor explainability of algorithms in terms of calibrated confidence or clinically relevant attention. Therefore, during the development of these algorithms, tools and mechanisms should be employed to ensure that they are not only accurate, but that they are transparent and trustworthy for clinical deployment and can enable clinicians to make more informed decisions. When looking at techniques to optimize the clinical relevance of an algorithm's attention, self-attention mechanisms show great potential. In our previous research, we found that the addition of self-attention in standard CNNs leads to major improvements in performance. But more importantly, based on a clinical user study, we found that self-attention mechanisms significantly improve the focus of algorithms towards regions of clinical importance. When such developments in explainable AI are applied to medical image analysis, they have the potential to significantly improve the trustworthiness of AI. The other component of algorithms that is necessary to tune for transparency is prediction confidence. An algorithm's confidence in a prediction is highly beneficial in enabling clinicians to gauge uncertainty. However, various off-the-shelf CNNs, such as ResNet, are prone to overconfidence. Similar to attention, this is another component of algorithms that is not represented through performance-based metrics and is therefore not very widely addressed. One technique that has the potential to improve medical confidence calibration is modern data augmentations. Although these are very effective, they are randomized and performed pre-training, and therefore risk the loss of important features on medical images. They can also reduce the clinical value of smaller datasets. We aim to create a framework that could use targeted clinician feedback to achieve a twofold impact on models apart from just accuracy. First, more clinically relevant attention, and second, higher levels of confidence calibration. As algorithm training methodologies continue to become more automated, requiring less clinical intervention, we decide to propose a more interactive approach to training medical image analysis algorithms. IMIL, or the Interactive Medical Image Learning Framework, is an intermediate training callback that enables clinician-guided data augmentations. By enabling clinicians to control augmentations during training, IMIL prevents the wrongful removal of clinically relevant information while also helping force the algorithm to correct mispredictions by shifting attention to more relevant context. The IMIL callback can be called at any point during training. At whichever point it is called, it will find the most significant misprediction outliers and present them to the clinician. Then, by presenting the clinician with the localization grid over the image, similar to Google's CAPTCHA, along with the saliency heat map representing the model's current focus, the clinician can choose regions on the grid that contain clinical features that best correlate to the ground truth label. After this, the image is augmented by removing all irrelevant grid regions, which we call blackout. Training will then continue with the model learning from the updated images for the subsequent epochs. The IMIL framework is configurable based on a few parameters. The IMIL epoch represents the point at which IMIL will be called during training. The grid size is used to customize the amount of regions from which the clinician can select to provide feedback as input to the augmentation, for example 3x3 or 4x4. The num outliers parameter is used to determine how many misprediction outliers or hallucinations IMIL should find in the dataset to request clinician feedback on. The misprediction outlier selection is the first stage that starts at the specified IMIL epoch. At this point in training, predictions are gathered across the full training dataset to find all of the mispredictions. The final outliers are based on the num outliers parameter and are gathered with the objective of honing in on the strongest model hallucinations to effectively target clinician feedback. To do so, the highest confidence mispredictions are used. The interaction stage of IMIL enables targeted feedback to generate meaningful data augmentations. For each of the misprediction outliers, the clinician will be able to refocus the algorithm through interaction with the localization grid. Based on the predefined grid size parameter, a grid of equally sized squares will be overlaid on the image for the clinician to choose from. To ensure that the clinician makes an informed decision on grid selection and how to best relocate attention, they are jointly provided with the current prediction, confidence, along with the corresponding saliency heat map. We propose the blackout augmentation to remove the grid regions of the image that were not selected and only retain relevant visual features. The objective of this is to force the algorithm to associate the target label with relevant features for downstream training and to correct the misprediction. Such an approach is also used with efforts of improving the clinical relevance of attention across other images in the dataset. Our clinical user study aimed to validate the efficacy of IMIL using 3 radiology residents at Stanford Medicine. We used ResNet 50 as the baseline algorithm and trained it on the NIH Shenzhen No. 3 People's Hospital dataset for tuberculosis classification. We configured IMIL to train the algorithm for 100 epochs and to initiate the interactive feedback mechanism at the 70th epoch for each of the 3 separate training sessions, with the outlier count being 20. Before obtaining feedback from the residents, they are briefly instructed on how to interpret the output of IMIL for each of the misprediction outliers. They were also briefed on the objective of providing feedback, which is to shift model attention. Shown here are examples of IMIL interactions for each resident along with the generated augmented image. These samples also contain a brief reasoning provided by the resident on the clinical intent behind their grid selection. All IMIL models present performance improvements over the baseline in terms of accuracy and AUROC. In terms of accuracy, the resident 1 and 2 models outperform the other state-of-the-art modern augmentations as well. In terms of AUROC score, all the IMIL algorithms outperform the baseline, cut mix, and cutout. Mixup has the highest AUROC score. IMIL led to a considerable improvement in performance considering that it used clinician feedback to augment only 4% of the dataset. We used ECE, or the expected calibration error, to gauge the changes in confidence calibration induced by training. Cutout was the only algorithm that increased calibration error, while all other models led to improvements in calibration. Although the IMIL models for all residents did not have error rates lower than cut mix or mix-up, they do reduce ECE considerably, again considering the low outlier count of just 20 images. We further looked at the effects of IMIL on algorithm attention compared to the other augmentations using the highest performing variant, which was resident 1. It was evident that the baseline focused on the lung and hilar lymph nodes, mainly in the lower and middle zones. Mix-up had attention which was mainly on the upper lung zones. Cut mix had a patchy, heterogeneous focus on the lungs, and cutout had the least focus on lung fields, sometimes even on the shoulder or thorax tissues. On the other hand, the IMIL model had heat maps covering all the lung fields and hilar lymph nodes effectively. In this study, we presented IMIL, the interactive medical image learning framework that enables clinicians to provide feedback during training to enable clinically relevant augmentations with the aim of shifting attention and preventing downstream mispredictions. IMIL shows the potential of using clinician guidance to prevent the risk of losing important information and data, especially when dealing with scarce clinical datasets. The highest performing IMIL model led to around a 4% increase in accuracy while only using 4% of the dataset to perform augmentations. Furthermore, IMIL presented benefits in both improving the clinical relevance of attention and confidence calibration. Our study demonstrates the potential of using clinician input to control augmentations, and we hope this approach can improve the value of medical image datasets. Thank you.
Okay, thank you very much. And we still have